Test. Test mic. Mic test. 1, 2. Test mic 1, 2.
Already? Okay. Okay. Bismillah ar-Rahman ar-Rahim. Alhamdulillah, salatu wassalam ala Rasulillah. Good morning, everybody, and welcome to our second day of the Masterclass of GI and GU cancer. Today, we're going to have, inshallah, another rich scientific day with our eminent speakers and moderator. The first session will be about the gastroesophageal and hepatobiliary cancer. It's my pleasure to moderate this session with my dear friend and colleague, Dr. Kanaan Shamri, who is a consultant medical oncologist at King Abdulaziz Medical City. For our virtual attendees, please post your question and answer box, and we will be happy to direct it to the speakers. Thank you very much. Please, Dr. Kanaan.
Assalamu alaikum. Good morning, everyone. It's my pleasure, as always, to be part of these great academic activities. And it's also my pleasure to present excellent and speakers. And I want to have the pleasure and actually present Dr. Ali Zahrani, who is a senior GI oncologist who practices his practice at King Fahd Medical City, and he is going to delight us by talking to us on the updates of the management of HER2 mutated advanced GE junction cancers. Dr. Ali.
Bismillah ar-Rahman ar-Rahim. Wassalatu wassalamu ala Rasulillah. Thank you, Mr. Chairman. Very thankful for Dr. Ashwag, Dr. Muhammad, and Dr. Kanaan for the invitation. So I will talk about the update on the management of HER2 advanced gastroesophageal cancer. Gastroesophageal cancer is a not very uncommon type of tumor. Around 1.6 million had been diagnosed year 2020, 1 million gastric and 600,000 esophageal cancer. Unfortunately, the prognosis is not that great. Only 5% of patients would survive 5 years after diagnosing them with metastatic disease. In Saudi Arabia, the stomach cancer is ranked as 14th, and the esophageal cancer is ranked as 22nd. And again, most of the patients, unfortunately, would succumb their disease when it is metastatic. The gastric cancer is a notorious type of cancer. The heterogeneity is really very abundant in the gastric cancer. There are many levels of heterogeneity, but the most important two are the intratumoral and intertumoral heterogeneity, which is really make the choice of treatment and the targeting areas really very difficult to decide for the treatment of such patients. So the intertumor heterogeneity actually started in 1965 when Lorraine had divided the histopathology of gastric cancer into the intestinal and diffuse type, the inner circle here. And this was accepted by WHO and even divided further to tubular, papillary, mucinous, medullary, and polydifferentiated signet ring. And this actually even expanded even further with molecular subgroupings into CIN and MSI and other types that actually indicated that these patients might actually be targeted with different type of tumors. Not only that, but recently, immunological subgroup had been added to this type of heterogeneity, and now the tumor can be divided into hot and cold depending on the response of the immunotherapy. The intratumoral heterogeneity is really very clear in the HER2 positive and negative type of gastric cancer. As you can see here, the red cells are the HER2 positive and the blue cells are the HER2 negative. So in this scenario, this type of patients have a positive test by immunohistochemistry and by the FISH. But when you look to the response, it is not always positive. Sometimes the HER2 negative are the one that metastasizing, ending up with a resistant type of tumor. The second scenario, when you have a negative test by taking biopsy from the negative cells, but again, maybe part of the tumor is HER2 positive, and these are the tumor that metastasize, and sometimes you end up with response of patient where you have negative results by immunohistochemistry and by FISH. Sometimes actually you will have both positive and negative at the same time, and this depends on the biopsy that was taken. Sometimes you take biopsy from both sides at the same time, and maybe also here is resistant because the one that metastasizing is the one that is not having the HER2. So this really reminds us of the Greek mythology, the Achilles heel. You really need to choose the right weapon at the right time and aim it to the right target so you can have an effective kill. So the HER2 scoring system for gastric cancer is a little bit different than breast. It actually depends on the intensity of the staining. Not only that, but if you have the whole specimen, then this needs to be positive in at least 10% of the tumor. That's why the CAB ASCO had come up with the recommendation for the HER2 testing for gastric cancer, and they recommended to have at least 5 biopsies to be sure that this type of tumor is either HER2 positive or negative. So what is HER2? HER2 is a family of epidermal growth receptor. We have HER1, 2, 3, and 4. They are consisting of extracellular, transmembrane, intracellular, and they are targeted by either homodimers, when the HER2 is combined with the HER2, or heterodimers, mainly HER2 with HER3. And these inducing a cascade of reaction by RAS-MAP kinase, and they end up with prevention of apoptosis and increase in proliferation and increase in incidence of metastasis. So HER2 is located at chromosome number 17, and it is mainly due to amplification of the gene. And we have 2 types of testing, the immunohistochemistry and the FISH. And the one that have 2 pluses in at least 10% of the cells, and FISH positive or 3 pluses are the ones that are considered HER2 positive. So the HER2 can be targeted at different levels, extracellular or intracellular tyrosine kinase part, and there are 3 main types of treatment that can be offered: the monoclonal antibodies, the tyrosine kinase inhibitors, and the antibody drug conjugate. The one that really showed some clinical benefit are the trastuzumab and trastuzumab deruxtecan, and I'm going to talk about this in more detail. So the most famous and still the most important trial that had been published since year 2010 is the TUGA trial. TUGA trial was presented at the beginning in 2009 ASCO, where more than 590 patients had been randomized to receive trastuzumab with chemotherapy or only chemotherapy. The primary endpoints were progression-free survival and overall survival. And it was a positive test. Not only that, but the positivity was really more great for those who are having more intense staining of HER2. Those with the immunohistochemistry 3 pluses and those with 2 pluses and FISH are the ones that made actually a larger median overall survival of around 6 months. Unfortunately, the subsequent trial in first line and second line did not have the same success. They have used many anti-HER2, but unfortunately, most of these trials were negative. And the explanation for this is really multifactorial. One of them is the one that I have mentioned, intratumoral heterogeneity. And the other possibility is the activation of downstream, even without a connection to the HER2. Some of the cases, there was some RAS-MAP kinase activation, or even another pathway like MET, or sometimes mutation of HER2 or loss of target, like HER2 are the one that cause these resistance. Sometimes even the mechanical blockade with mucin. Sometimes presence of a lot of mucins around the tumor might actually block the effect of anti-HER2 to these type of cells. So what are the strategies that can help treating those patients? We have, 5 strategies that had shown some clinical benefit up to now. We'll start with the first one, combining the anti-HER2 with anti-PD-L1 or anti-PD-1. And this actually had shown some interesting preclinical synergism. And the rationale behind this is that the trastuzumab actually induces antibody-dependent cellular phagocytosis, and the chemotherapy, especially oxaliplatin, when it destroys the tumor, it actually presents a lot of antigen to the dendritic cells. So in theory, this would actually make the tumor more hot and make it more immunogenic. And this is what had been shown in some preclinical trial. Because of these preclinical trial, the very famous, the 2 very famous phase 1 and 2 trials, one American and the other one is Korean, Banthera trial, they have tried using pembrolizumab with trastuzumab and chemotherapy in patients with who are HER positive, and the objective response rate was ranging from 70% to 90%. Because of this, the Keynote 811 had been actually started, and using trastuzumab, pembro, and chemotherapy for HER2 positive. The interim analysis had been published more than a year ago in Nature, and the objective response rate was actually improved by more than 22%, from 50 to 74%. All subgroup had shown improvement. The overall survival and progression-free survival are still pending. Possibly we'll have some result about this trial at the end of this year or possibly early next year. Because of this, the FDA had granted accelerated approval of pembro to HER2 positive gastric cancer with the chemotherapy. The other important strategy is the antibody drug conjugate. This is really a very interesting way of treating HER2 positive gastric cancer. The most important drug is trastuzumab deruxtecan. Trastuzumab deruxtecan is really an interesting medication. It is composed of humanized anti-HER2 IgG monoclonal antibodies combined to a topoisomerase 1 inhibitor, the deruxtecan, with a linker. This linker is very stable in the plasma, but when it reaches inside the tumor cells, it can be actually cleaved. And when it is cleaved, it can actually even go outside of the tumor cells to the neighboring cells that doesn't have HER2, and there is some sort of bystander hit. So this type of treatment actually can kill the cells that harbor the HER2 and also the neighboring cells. The topoisomerase 1 inhibitor is very effective. It is 10 times more than the irinotecan. So by principle, this combination is really very interesting combination to be used. And this what had been shown actually in Destiny Gastric 01, an Asian trial, randomized phase 2 trial, 187 patients for patients who are received 2 lines before. And as you can see here, the objective response rate was 51% compared to 14%. Not only that, but the progression-free survival and overall survival was also significantly better for trastuzumab deruxtecan compared to the chemotherapy. The drug discontinuation, drug interruption was higher. The complication was mainly bone marrow and GI toxicity. There was 1 treatment-related death due to pneumonia, and this is possibly because of the pneumocide is taking more of the drug because of certain receptor on that pneumocytes. Because of this trial, this drug had been approved for 3rd line and beyond in Japan, and also was approved in America for 2nd line and beyond, but with the recommendation of taking biopsy to confirm the positivity of HER2. Destiny Gastric 02 study is similar to Destiny Gastric 01 study, but this time in Western patient with a comparable outcome, as you can see here, with less side effect on the Western patients. An interesting trial, the Destiny Gastric 04. It's really interesting trial that we're all waiting for. It is a randomized phase 3 trial comparing trastuzumab deruxtecan to the standard paclitaxel ramucirumab, more than 490 patients, and hopefully we'll have a standard after this trial is going to be, we're going to have some result from this trial. Another interesting way is combining trastuzumab deruxtecan with chemotherapy or with anti-PD-L1. And this is phase 1/2 trial. In the phase 1 had been, reported. It showed that the maximum drug dose was 6.4 milligram per kg. And when it was combined with capecitabine or 5-fluorouracil, the objective response rate was 71%. So hopefully this will give us even more effect when this combination is going to be standard in the future. How about tyrosine kinase inhibitor? Possibly the most important one is tucatinib. Tucatinib had showed a positive result in breast cancer and also recently in colon cancer with trastuzumab. And it is a very peculiar drug. It is more potent than other tyrosine kinases, 1,000 potent actually, and it is very specific to HER2. This was actually done in a phase 2/3 trials with combination of trastuzumab and paclitaxel ramucirumab. And then after phase 2 is going to be successful, then they're going to have a phase 3 arm comparing this to placebo. At the same time, there is a phase 1b/2 for first line, and we're going to have about some results possibly in 1 or 2 years. How about the bispecific monoclonal antibodies? A very interesting way of treating HER2 positive gastric cancer is actually some sort of monoclonal antibody with 2 sites, 2 epitopes. One epitope affecting the pertuzumab site, and the other one affecting the trastuzumab site. The preliminary phase 2 trial showed that the objective response rate is around 30%. And when it is combined with the chemotherapy, this objective response rate is actually increasing to around 75%. Immunotherapy, cellular and antibodies. This is really very interesting. Was there a problem? You want me to repeat? No. So we know that CAR-T is effective in hematological malignancies, but it is not very effective in solid tumor. So CAR-M, actually this time, using a chimeric adenovirus vector introduced into monocytes and macrophages, it was shown that the CAR-M actually is effective, and it showed that actually it induced some immunoreaction when it is used in patients. And this actually now is going to be studied in a phase 2 trial. Vaccination also against HER2 showed that several injections actually induced HER2 specific IgG, and the combination of vaccination with chemotherapy has shown a promising result with improvement in overall survival in phase 2 trial. So what's happening now in the guidelines, the trastuzumab in first line is still standard, and pembrolizumab actually also was added, but without a category characterization, waiting for the final result of Keynote 811. In a second lines, trastuzumab deruxtecan is also there in NCCN guidelines, but again, there is no recommendation for it until now. In the ISMO guidelines, they are still sticking with the trastuzumab only the first line and nothing else. So to conclude, trastuzumab chemotherapy, TOGA trial is still the superstar. We're still using it up till now. We might add PD-1, pembrolizumab, if according to the local regulation in hospitals, trastuzumab deruxtecan, although there is regulatory approval, but still not standard up to now. I think the emerging targeted agents is there and going to be of major benefit, especially to tucatinib in the near future. But the others are really also promising. Thank you very much.
Thank you very much, Dr. Ali, for an excellent talk, as always. Now it's my pleasure to introduce Dr. Ahmed Al-Shihri, who's a senior GI and breast oncologist who practices at National Guard, Jeddah. He is going to update us on immunotherapies for advanced GE junction or GE cancers, what agent and what biomarker. Go ahead, Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I would like first to thank my dear colleague and friend, Dr. Kanaan, for his nice introduction. To thank Dr. Muhammad Al-Garni, Dr. Ashwaq Al-Alayyan for the successful organization of this meeting. It's always hard to talk about an eminent speaker like Dr. Ali Zahrani. I always enjoy his talk. When he talks about, general GI or head and neck cancer topics. Thank you, Dr. Ali. You made my task a little bit more difficult here. So I was supposed to talk about the immunotherapy in upper GI cancers, namely esophageal and gastric cancer. Dr. Ali, nicely and elegantly presented, the epidemiology about this problem in our country. And we know that gastric cancer has a poor prognosis. We didn't used to have a lot of useful options as a treatment in this kind of cancer. Most of the patients, we used to have their overall survival less than 12 months until recently, where we started to have more effective kind of treatment options with more targeted kind of therapies like the HER2, as nicely presented by Dr. Ali Zahrani. These are usually the molecular kind of biomarkers we always think about in the first line setting. HER2, to consider any of the anti-HER2 therapies that were discussed by Dr. Zahrani. And then we have the MSI status or MMR deficiency status. And then we have the PD-L1 testing status, because these also will dictate on us whether not to use one of these checkpoint inhibitors or immunotherapies, whether in first line, second line, or third line. I'll talk about starting with gastric cancer. What kind of evidence do we have to use immunotherapy or checkpoint inhibitors? Checkpoint inhibitors have been introduced in the gastric cancer era in the third line setting. Then when it was approved, then they tried it in the second line. Then when it was approved, then they tried it in the first line. So I'll start first by the third line setting. All of us are aware of the Attraction 2 study, Attraction 02. I know my dear colleague and friend, Dr. Ali, he doesn't like to use it based on this clinical trial, at least based on the discussion that we had before. But this is a phase 3 study that have tested nivolumab versus best supportive care in those patients who failed at least 2 lines of chemotherapy or systemic therapy. They used the standard dose of 3 milligram per kg every 2 weeks. They didn't use any biomarkers here. If you look into those patients, you're going to see that the vast majority, more than 80% with gastric cancer, more than 80%, they received at least 2 lines of chemotherapy. So the vast majority of these patients were in the third line and beyond. So they are a bit heavily pretreated. You can see 40%, they received even 3 or more lines of treatment before randomization to nivolumab versus best supportive care or placebo. You can see that nivolumab as a monotherapy has introduced an overall response rate of 12%, which is not bad for an immunotherapy without any kind of biomarker. You can see that the overall survival has improved from 4.1 months to 5.3 months. with a 38% reduction in the risk of death by having nivolumab as a monotherapy. You can see the 12 months overall survival almost doubled from 12% in the placebo arm to 27% in the nivolumab arm. And this kind of benefit to nivolumab was independent of PD-L1 status, whether PD-L1 negative, PD-L1 positive. We see that nivolumab was working in both groups. And when we looked into those people who showed some evidence of response, either partial response or even complete response, we can see that the median survival has exceeded more than 2 years in these patients. Remember, those are heavily pretreated. They received at least 2 or 3 lines of chemotherapy before randomization to nivolumab. And yet, for those who showed some evidence of response, they had a median survival of more than 2 years. Even those people who have a stable disease with no evidence of response, they had an improved overall survival. However, the benefit was a little bit smaller than what we have seen in complete or partial responders. This is for nivolumab. Phase 3 trial has set nivolumab as a standard of care in the third-line setting. What about pembro in the third-line setting? Pembro have been tested in a single-arm study, so there is no comparator arm there, and it was tested in patients again who failed at least 2 lines of treatment. I mean, from second line and beyond. You can see that 50% of those patients, they received pembro in the second line setting, which means that those patients in general are less heavily pretreated in comparison to the Attraction 2 study. You can see that the efficacy data were comparable to nivolumab. So the overall response rate was 12.6%, progression-free survival 2 months, and overall survival 5.6 months, which is quite comparable to nivolumab. However, the pembro, as opposed to nivolumab, we didn't have any signal of subgroups that benefited more than others. However, in pembro, there are certain predictors of response when we talk about overall response. Of course, PD-L1 positive with a CPS score of 1 or more, they drive more benefit as compared to PD-L1 negative. Those who receive this kind of treatment in the third line and earlier, they drive more benefit as compared to those who received it in fourth line and later. And of course, if the patient was MSI high, they drive like significant benefit. The response rate was reported 57% as opposed to 9% in microsatellite stable patients. So if you consider using pembro on the third line setting, you have to look into these predictors. PD-L1 positive, it has to be third line and earlier, or MSI high, okay, to consider pembro. And remember, this is based on a single arm study, is not a randomized study, as opposed to nivolumab, which is in a phase 3 trial compared to placebo, and it showed a benefit regardless of the any kind of predictor. So this will summarize third line treatment, nivolumab, pembrolizumab in gastric cancer. What about second line? Second line, we have only one study in pembrolizumab, is the Keynote 061. This is an interesting study because the primary endpoint was to prove overall survival in CPS score more or 1. And this was not proven. The pembro was not better than chemotherapy, which is paclitaxel, the comparator arm here, was not better than paclitaxel in CPS score more on 1 or more. However, when they did a post hoc analysis, they found that those who have PD-L1 score more than 10, or those who have MSI high gastric cancer, they derive significant benefit from pembro as opposed to chemotherapy. So the primary endpoint of this study was not met, but when they looked into post hoc analysis for CPS score more than 10 or MSI high gastric cancers, they found that pembro was superior to the second line paclitaxel chemotherapy here. So we have some debate about this study and the results, given the fact that the primary endpoint was not met here. When we go to the first line setting, gastric cancer again, there was the Keynote 062, which is another study. It's a three-arm study, pembro, monotherapy, pembro plus chemo, or chemotherapy. The chemotherapy here was 5-FU and cisplatin. And they consider CPS score more than 1 or CPS score more than 10. The interesting point that in CPS score more than 1, the pembro was non-inferior to chemotherapy. So non-inferiority was proven for Pembro as a monotherapy. Pembro plus chemo was not better than chemotherapy alone. So the Pembro plus chemo is dead here as based on this clinical trial. When we look into the CPS score 10 and more, we can see Pembro as a monotherapy, when we talk about overall survival, was better than chemotherapy. Not non-inferior, was better than chemotherapy, while Pembro plus chemo was not better than chemotherapy alone. So based on this study, monotherapy, Pembro monotherapy is non-inferior to chemotherapy in CPS score of 1 and more. Pembro as a monotherapy was better than chemotherapy when we consider CPS score 10 and more. Pembro plus chemo was not superior and was not better than chemotherapy alone, whether CPS score 1 or CPS score more than 10. Not only this, when we looked at the MSI high status, we can see that Pembro was superior to chemotherapy, whether in the second line setting, paclitaxel, as we mentioned in the previous study, or even when we consider the first line chemotherapy, 5-FU and cisplatin. So to conclude this study, which is the Keynote 062, we can see that Pembro as a monotherapy is non-inferior to chemotherapy, CPS score more than 1. CPS score more than 10, Pembro monotherapy is superior to chemotherapy, and MSI high population, Pembro as a monotherapy is superior to chemotherapy. And I think all of us now, we know about the landmark study, the Checkmate 649, which has changed the clinical practice in most of the oncology centers in our country using first-line chemotherapy, either FOLFOX or CAPOX plus nivolumab in the first-line setting of chemotherapy of gastric cancer. So you can see this is a randomized. It was a 3-arm study using nivo plus chemotherapy, either FOLFOX or Zelox versus chemotherapy alone. There was a third arm, which is dual immunotherapy, and this arm was deleted because of the toxicity. The dual primary endpoint of this study was overall survival and progression-free survival in CPS score of 5 or more. You can see that the primary endpoint was met when we talk about overall survival, that nivo plus chemotherapy was better than chemo alone. You can see that the overall survival has improved from 11.1 months to 14.4 months with a significant p-value, as you can see here. Not only this, when they consider CPS score more than 1, which represent more than 80% of the population, still nivo plus chemo was better than chemo alone. When they consider all patients, all randomized patients, remember, all randomized patients, more than 80% are PD-L1 positive and less than 20% are PD-L1 negative. But when they consider all randomized patients, nivo plus chemo was better than chemo alone. This is with regard to overall survival. Progression-free survival was the same, that nivo plus chemo was better, talking about CPS score of 5 or more, and all randomized patients, nivo plus chemotherapy was better than chemo alone when we consider the progression-free survival. The same for overall response rate. It was better in favor of nivo plus chemo, has improved from 45% to 60% by adding nivolumab to the chemotherapy. And this is true for the PD-L1 positive and all randomized patients, as does the duration of response was in favor of nivolumab. The interesting part here that MSI high, which we know it's one of the most powerful predictor to response to checkpoint inhibitors, again, we can see that adding nivolumab has improved the median survival significantly from 12 months for chemo alone to almost 38.7 months for nivolumab plus chemotherapy. So this is a huge kind of improvement in favor of nivolumab, addition of nivolumab. But most importantly, even in the microsatellite stable population, the median survival significantly improved by nivolumab. So the fact that the patient is microsatellite stable does not rule out the benefit of nivolumab, addition nivolumab to chemotherapy. The quality of life and the health-related quality of life was not negatively impacted by addition nivolumab. So nivolumab gave us the clinical benefit without affecting the quality of life. And with regard to toxicity, the same kind of toxicity profile that we know about checkpoint inhibitor, nothing significant was reported there. It's a busy table here, but I tried to summarize all the immunotherapy trials in gastric cancer. In the third line setting, I think nivolumab, without having any predictor, would be the best agent to be used if patient missed the chance to have immunotherapy in earlier lines of treatment. In second line, there is a big debate about the role of pembrolizumab as opposed to chemotherapy because the primary endpoint was not met. However, when we consider CPS score of 10 and more or MSI high, probably pembrolizumab might be better than chemotherapy. In the first line setting, I think the best agent would be nivolumab plus chemotherapy, as we have seen in this study, specifically talking about CPS score of 5 or more, regardless of MSI, whether MSI high or microsatellite stable. Pembrolizumab in the first line setting might be considered as a monotherapy if we are talking about MSI high gastric cancer. So when we talk about immunotherapy in gastric cancer, the best setting I see, in my humble opinion, either to use the chemotherapy plus nivolumab, especially in CPS score of 5 or more, or pembrolizumab in MSI high gastric cancer. If the patient missed the chance of having immunotherapy in the first line setting, I would use nivolumab in the third line setting without having any biomarker there. Let's move on to esophageal cancer. Again, esophageal cancer, the immunotherapy was tested in the second line setting. The pembrolizumab was tried in the keynote 180 as a monotherapy in a single arm study. And the benefit, there was a signal of benefit when we talk about esophageal squamous cell carcinoma and PD-L1 positive patient. And this is why they run the phase 3 trial keynote 181, which is well known to most of us, where pembro was compared to standard second line chemotherapy at that time, paclitaxel, docetaxel, or irinotecan. And you can see that the outcome, which is overall survival, the primary endpoint, was only significant if we consider that the CPS score more than 10. CPS score more than 10, pembro was better than chemotherapy. And that kind of benefit was histology dependent. So when they randomize those patients or stratify those patients to squamous cell versus adeno, they found that the benefit was restricted to squamous cell carcinoma. So pembro is better than chemotherapy if you consider CPS score of 10 or more and was esophageal squamous cell carcinoma in the second line setting. What about nivolumab? Also have been tested in second line setting. First, in the Attraction 1 study, it was a single arm study which showed a 17% response rate in esophageal squamous cell carcinoma. So this study was restricted. Nivolumab studies in esophageal cancer, all of them were squamous cell carcinoma. And then it had been tested in the Attraction 3 in the second line setting, nivolumab versus standard chemotherapy in the second line setting, docetaxel, paclitaxel, all of them were esophageal squamous cell carcinoma, and the primary endpoint was overall survival. And it was a positive trial that nivolumab was better than chemotherapy, and there was no predictor for response. So we didn't have the benefit was seen whether PD-L1 positive or negative. What about first line in esophageal cancer? We all know about the Checkmate 648, which is a 3-arm study, nivolumab plus chemo, nivo, ipi, the dual immunotherapy, or chemotherapy alone. And the primary endpoint, actually co-primary endpoints, overall survival, progression-free survival, and PD-L1 score of 1 and more. Again, this is only squamous cell carcinoma. We said that all nivolumab studies in the esophageal cancer were esophageal squamous cell carcinoma. The primary endpoint was met, that nivo plus chemo was better than chemo alone with regard to overall survival in PD-L1 1% or more. And when they run all randomized patients, including the PD-L1 negative population, also nivolumab plus chemotherapy was better than chemotherapy alone. And this is true also for progression-free survival. The addition of nivolumab to chemotherapy was better than chemotherapy alone, whether in CPS score more than 1 or randomized patient, there was also a trend. The interesting point about this study, what about dual immunotherapy? Like nivolumab, ipilimumab. We can see here at the beginning, when we talk about overall survival and progression-free survival, we can see at the beginning the chemotherapy was better than the dual immunotherapy. But at around maybe 6 months, there was a flip of the curve. The same kind of story that we have seen in several other trials. There was a flip where immunotherapy was far better than chemotherapy. This is beyond 6 months. Once we have those patients who are immunotherapy resistant or refractory, they have been kicked out of the study. So the same true for the progression-free survival. So even the dual immunotherapy, nivolumab, ipilimumab, was better than chemotherapy in overall population or randomized patients, and those patients with PD-L1 positive of 1% or more. And this might open the door to a chemo-free treatment for those patients who are not candidate for chemotherapy as esophageal cancer. We might consider that as an attractive option in those patients. Again, the toxicity profile was not, there is no big alarm or alert from toxicity point of view using such combinations. Another landmark study is the Keynote 590 in esophageal cancer, first line. And this is including esophageal adenocarcinoma, esophageal squamous cell carcinoma. It's a simple design study, Pembro plus chemo versus chemo alone. The chemotherapy here is 5-cisplatin. It had been given up to 6 cycles, then they stopped the chemotherapy and they continued either the Pembro as a monotherapy or the placebo. Again, dual primary endpoint, overall survival and progression-free survival. They didn't put PD-L1 or CPS score as a mandate for the primary endpoints here. You can see here, if you consider the all randomized patients, you can see that the overall survival has improved by adding Pembro to chemotherapy, significantly improved. You can see the median survival was 9.8 months versus 12.4 months with a hazard ratio of 0.73. And the same kind of benefit was seen in esophageal squamous cell carcinoma. The same kind of finding of progression-free survival. There was an improvement by adding Pembro to chemotherapy as opposed to chemotherapy alone in the total population and in esophageal squamous cell carcinoma. We can see when we look at the subgroup analysis, the benefit was seen in adenocarcinoma, in esophageal squamous cell carcinoma, and this benefit was also seen in PD-L1 positive or CPS score more than 10 or CPS score less than 10. And this is true for overall survival and progression-free survival. Overall response rate also has improved. Duration of response has improved in favor of adding pembrolizumab. And this is why the Pembro plus chemo has been approved in esophageal cancer in the first line setting without need for PD-L1 testing. The quality of life was maintained and was not affected by adding pembrolizumab. No big alarm or alert from toxicity point of view by adding Pembro to chemotherapy. So to summarize, the immunotherapy in esophageal cancer, once again, we have second line setting, nivolumab attraction 3, and this has included only esophageal squamous cell carcinoma, and it was shown to be superior to chemotherapy in the second line squamous cell carcinoma of the esophagus without need for any other predictor apart from the histology itself. It has to be esophageal squamous cell carcinoma. While Pembro in the second line setting, it showed a benefit if patient is having CPS score more than 10 and squamous cell carcinoma. In the first line setting, Pembro plus chemo was beneficial regardless of any other predictor, the histology or the CPS score. There was a benefit in all these subgroups. If you consider nivolumab, you may consider that only in squamous cell carcinoma of the esophagus, because this is the only histology that have been included in the Checkmate 648 and in CPS score of 1 or more. The interesting part of this study that in those patients who are not candidate for chemotherapy, you might think of dual immunotherapy, nivolumab, ipilimumab, which have been shown to be better than chemotherapy in that setting. So these are the different lines of immunotherapies that I use in gastric cancer, esophageal cancer. I try to summarize it and I discussed it in like a detailed manner in the previous slides. And with that, I would conclude my talk and thank you for your attention.
Thank you very much, Dr. Ahmed, for outstanding talk as usual. Now we'll move to our next speaker and we'll switch gear to biliary tract cancer. It's my pleasure to invite my dear friend and colleague, Dr. Mohammed Al-Ghamdi, who's a Deputy Director of the Cancer Center at King Saud University Medical City and the Chairman of the Saudi Society of GI Oncology. He will talk to us today about updates on systemic therapy for biliary tract cancer. Please, Dr. Mohammed.
Thank you very much, Mohammed, Kanaan, and Shwag for the invitation. It's always a pleasure to be with you guys. So indeed, we're going to switch gear and talk about the biliary tract cancer. When it comes to the upper GI malignancies, it's not always a good news. And in my talk, I'm going to show you the impact of the changes that we have seen in the recent years and the advances and more options that we actually do in the clinical practice. So I'm going to talk a little bit of the epidemiology and the background, then talk about the standard first and second line therapy, some of the genomic alterations and the targets for these alterations. So we know that the biliary tract cancer is actually a heterogeneous group of diseases, including cholangiocarcinoma and gallbladder cholangiocarcinoma with extrahepatic and intrahepatic. Sometimes they include Ebola butter as a part of these group, and sometimes they included that side with pancreatic tumor studies. It account for about 3% of all GI malignancies, and unfortunately, most of these patients present late, and only up to 30% can be eligible for resection and then adjuvant treatment. And we know that the 5-year survival of such diseases usually typically less than 20%. This is basically the Global CAN 2020 cancer incidence and mortality, and liver cancer here is number 9, which includes hepatocellular and the biliary tract cancer. This is from the Saudi Cancer Registry, the latest one, 2018. As you can see, liver actually jumped just one step up in the in men and became number 6, or 7, sorry. And we don't see the liver cancer or the PTC in the female. When we talk about both genders, it comes to number 9 with a 3.1 incidence. And as you can see here, with the advanced in age, the risk of developing such cancer is growing up. And we know the commonest here is the HCC, however, cholangiocarcinoma, and the others are also included in this statistics. So we know, as we said, it's not one disease. Extra and intrahepatic cholangiocarcinoma, they have a different presentations, different clinical behavior, as well as different risk factors. We know that the cholangiocarcinoma, they have more predominant risk for men other than the gallbladder cancer. Gallbladder cancer, many cases presented incidentally after cholecystectomy. So what are the challenges when we talk about the biliary tract cancers? Usually they have a delayed diagnosis, so it's an advanced stage. They usually have non-specific symptoms, and when they present with, let's say, obstructive jaundice, it might be too late, and there is no adequate screening, and these population at risk is usually poorly defined. So now let's move on and talk about what is the standard of care in the first line treatment. So that was actually published back in 2010, and basically they have added cisplatin to gemcitabine. That was considered to be the standard of care, and we have 2 landmark studies, ABC and BT22. Basically, they have similar result with improvement in overall survival when we add cisplatin to gemcitabine. This is a meta-analysis of both trials, and both showed all the subgroup analysis, regardless of the type of the biliary tract, men or women, apart from a poor performance status, they might not have the best outcome. So what can we do to improve this? So shall we replace one of the agents with the other one? And indeed, the Japanese group did that, and they have replaced or tried to compare S1 with the cisplatin, the standard of care, but it was a negative study in terms of the overall survival, progression-free survival, as well as the response rate. So can we do something else? Can we add another agent to improve the outcome? This is a phase 2 trial that was published in JAMA a couple of years ago. And basically, they added nab-paclitaxel to the standard of care with the two step doses. Basically, there was 45% partial response rate and a disease control rate of 84%, which is significant, although this is a phase 2. Not only that, the progression-free survival was 11.8 with a median overall survival of 19.2 months. That's why they are actually doing an ongoing now the phase 3 trial with same concept of adding nab-paclitaxel to the standard of care. We and the final data collection will be next year in January 2024. So we will be waiting for, I believe, a good result of this trial. So shall we change the regimen at all? So we try something else. So modified FOLFIRINOX was actually compared to cis-gem in this subgroup of patients, and it was negative. Actually, just gem-cis was superior in terms of overall survival and progression-free survival, so it did not change the practice. How about adding the S1 to the regimen? So the Japanese group again tried to do this by adding the S1 to the combination of gem and cis, and basically there was no much benefits added in terms of overall survival. However, there was some improvement in progression-free survival and response rate with a disease control rate, so it didn't really change the practice. So until recently, durvalumab, when it combined to gem and cis in TOPAZ-1 trial presented, that's actually opened the more options for these group of patients. So basically, this is a phase 3 trial, randomized, placebo-controlled, with the first-line treatment. They have added Durva to the standards of care, cis and gem, versus cis and gem with matched placebo for up to 8 cycles, then a continuation with either placebo or Durva, depends on the allocated randomization. Primary endpoint was overall survival with a multiple secondary endpoints, including progression-free survival, overall response rate, duration of response. So typical inclusion criteria and exclusion criteria for the trial, the baseline, the demographic between the two groups were matched, and as you can see, almost 50% of patients, they were from Asia. And intracolangiocarcinoma was also more than 50% in both groups. So it was a positive study in terms of improved overall survival with a hazard ratio of 0.8%. And as we can see here, with time, the curve is separated more and more. And on the 24 months overall survival, this is what we usually look and want to see in these patients, is the plateau of the curve. And based on the 2 years overall survival, that was granted an ISMO score of the clinical benefits of 4, which is one of the top scores. Subgroup analysis for all patients were in favor of adding Durva, including the PD-L1 expression, and they have used the tumor area positivity. Yes, we can see more of the benefits seen with the patients with more positivity score. However, all the group have got benefits from that. This is the progression-free survival, and as you can see, it was positive with a hazard ratio of 0.75. And when we look at the 12 months progression-free survival, it was 16% versus 6.6. Overall response rate also increased significantly when compared to the doublet chemotherapy, and the benefit seen was also compatible with the duration of the response disease. Side effects compatible between the two arms, and as you can see, the number are matching. Also, in terms of the grade 3 and 4, it was also compatible in both global anemia and neutrophils count. The immune-mediated adverse events, as expected, seen more with DOPA when added to cis and gem. Okay, so this is about the first line. Now let's move on to the second line chemotherapy. So until recently, there was actually no standard of care for the second line. And this was actually published back in 2019, and basically active symptom control versus FOLFOX with active symptom control with the primary endpoint of overall survival. And indeed, it was positive with a hazard ratio of 0.69. And the 12-month survival was increased from 11.4 with best supportive care to 25.9%. And that makes the FOLFOX with active symptoms control the standard of care for second-line treatment. These are a multiple and a small trials looked at FOLFIRI to be also used in the second line or beyond. Most of them single arm or retrospective, and as you can see, with a modest overall survival. Okay, can we do something else in the second line? So regorafenib actually was tried post platinum-based therapy, and there was no difference in overall survival. However, there was a statistical significant improvement in the progression-free survival. So it didn't really make it to the clinical use. Of course, other options, liposomal irinotecan was also tried in phase 2 AFTI trial, and there was a good improvement in terms of progression-free survival, overall survival, as well as the objective response rate. So let's now talk about the genomic alterations that's seen in the biliary tract malignancies. They have actually a different frequency and a different alteration when it comes to the location of the disease. As you can see here, extrahepatic, intrahepatic gallbladder, they have a bit different in terms of the frequency of these alterations. This is one of the clinical studies in 2017 presented in ESMO. Basically, they have screened more than 1,000 patients with advanced biliary tract cancer, and they ended up with 23 patients out of these 1,000 that might have some target treatment, and only 18 patients got treated. And those 18 patients, they had a benefit in terms of overall survival when it can compare to these patients with treated, not oriented, or they have no targeted treatment. So these are the target alterations in biliary cancers. I'm going to talk about these with a positive studies and positive outcomes. So FGFR, again, this is a FGFR2 is a member of the FGF family. Basically, they play a major role in proliferation, differentiation, angiogenesis. Basically, it's found in up to 15% of intrahepatic cholangiocarcinoma. And when it's targeted by anti-FGFR2, and this is one example, is pemigatinib. They tried it in second line after failure of platinum-based. And they have 3 arms, the FGFR2 fusion or other fusions or no alterations. And at the median follow-up of 17 months, the objective response rate was around 36%. And the disease control rate was around 80%. And the median duration of response was around 7.5 5 months, but there was no benefit seen in the other groups other than the FGFR2. This is the response rate in all patients. It was 35%. As you can see here, the overall survival in those patients with FGFR2 reached to 21.1 months. The adverse events of the anti-FGFR was the retinal detachment and dry eyes. Another agent, futapatinib, again tried in a similar fashion with FGFR2. Basically, we got similar like results in terms of response rate of 38 or 37.3% in terms of response, and the median time to response was 2.5 months, and the median duration of response exceeded 8 months. So do we have any other targets? So IDH1, again, Ghassan Abu Alfa and his group presented this in 2019 and updated in 2020. Ivosidenib, when it compared to placebo in the second or third line treatment after platinum-based in these patients with good performance status and IDH1 mutation. Basically, there was a benefit seen in terms of progression-free survival with a hazard ratio of 0.37. Although the overall survival was not statistically significant, but there was a trend toward overall survival, and that probably explained by the crossover seen in this trial. About BRAF, again, BRAF anti-BRAF agents tried in the metastatic biliary tract cancer reached, and it actually got 47% of all response rate with a median progression-free survival of 9 months. Now let's talk about the immunotherapy. So when we see the cholangiocarcinoma of the biliary tract, when we see the MSI high frequency, it's not really that much. And we're talking about 2% or less. And again, the PD-L1 expression, it's really varies. It can be from 8% to 46%. And there is also a lot of varies and threshold. So there is really no defined PD-L1 expression. And again, the tumor mutation burden seen up to 5% in gallbladder cancer. So I'm going to give you some of the examples. And so phase 2 nivolumab, again, got response rate of 22%, and they found that those with PD-L1 positive, they have an improvement in progression-free survival. Again, combining epi with nivolumab and the patients, but all of these patients, they had proficient MMR or microsatellite stable disease, and regardless of PD-L1 result, the duration of response also varies from 3 to 14 months. And all the patients who had a response were the intracholangiocarcinoma. carcinoma. Pembro monotherapy, again, and an advanced biliary tract cancer. These are 2 studies. And as you can see, the PD-L1 positivity was that is between the 2 group of patients, and the numbers of lines of therapy was a lot actually. So more than 3 lines was almost 50% in the keynote 0 to 8. Overall response rate was very modest with 5.8 in 158 study and 13% in 0.28. And again, these are the progression-free survival and overall survival for the 2 groups. So very modest activity. So we will use it unless we have an MSI. This is again the pembrolizumab that was used in the basket trial in non-colorectal MSI. So cholangiocarcinoma, there was 22 patients, and the median progression-free survival was 4.2 months, but the median overall survival was almost 2 years with pembrolizumab. A lot of clinical trials are actually coming, and in fact, just a few days ago, the MSD announced the positive result of pembrolizumab when added to CIS and GEM, and we're waiting for the details of this study in the upcoming conferences. About track fusion, and again, this is another basket trial. They looked at the efficacy of larotrectinib and track fusion patients, including some of the patients with cholangiocarcinoma. carcinoma. And as you can see, one of these patients got almost 70% decrease in the tumor size. Not only that, but also the duration of the response that can reach up to 15 months when treatment was given specific. So, this is the latest. It's not latest, but the same as this one. The principle of systemic chemotherapy in patients with advanced biliary cancer. So the preferred regimen still cis-gem with Dorba also added to the NCCN guidelines, and the second line, again, preferred options FOLFOX, unless there is some target that we can use to treat such patients. So chemotherapy with cis-gem between TOPAC and Dorba remains the standard first line treatment. We'll see about the Apraxane study when it's presented next year. I believe all these patients should have an NGS or MSI testing done upfront. FOLFOX is the second line standard of care if there is no target mutation, and so many ongoing trials. So we have to stay tuned. Thank you very much for having me.
Thank you very much, Dr. Mohammed, for this excellent overview about the biliary tract cancer management. Now we'll move to the last talk for the session about evolving landscape in treatment of HCC, to be presented by Dr. Ashwaq Al-Alayan, who's a consultant medical oncologist and the section head of medical oncology at King Abdulaziz Medical City.
Thank you, Mohammed and Kanan. And again, sorry for my voice. As you know all, that HCC have been changed for the last few years from like few options of therapy. Now we're struggle what to do for the first line and even for the subsequent therapy. So if we want to divide the treatment of HCC, probably the best way of looking at that is just systemic therapy or combination systemic with local regional, or the combination of the systemic therapy like it's like using 2 medication or more than 1 medication at the same time. So let's start with the single agent treatment. We know that like sorafenib stays for more than 10 years. It's the only drug that shows response and overall survival, and even PFS on the Asian specific trial, the SHARP trial. We know that difference was modest, but honestly, in real life, we have a good number of patients that have stayed even longer on this therapy. And here, if you look at the overall survival, we're talking about 10, but we know we have an extended follow-up and review, and even real life data that the overall survival for these patients almost like 13 months. So the first drug that came to the market, competing sorafenib as TKI, which is lenvatinib on the REFLECT trial, did not show a difference, honestly, in the progression overall survival, but the PFS show a difference almost like 3 months. So nivolumab, we have to talk about nivolumab, although it's been withdrawn on the treatment of HCC, but I think looking at the GI ASCO this month, there's a lot of new data talking about nivolumab in combination with even radioembolization. So I think nivolumab is gonna come back to the market. You know, this phase 1 and 2 trial was very exciting because the data was extremely good. We have real life data that collected by Kanan and Dr. Shehri and Dr. Faisal Sanai, and it did show there is a good survival advantage. So if you look at the patient who had sorafenib in the past, they have a median of 15 months. It's double when the patient is sorafenib naive. So this is the trial that killed nivolumab in the view of everyone, not exactly for me, which is the head-to-head comparison between nivo and sorafenib, which is the same basic characteristic. I don't think we have to repeat it all. The HCC data, it's child A, performance data, no prior systemic therapy. If you look here, that the overall survival was not really significant, but if you focus on the PFS at 22 months, 12 and 24 months, it's almost double. And overall survival also doubles. So if you believe it or not, I think it's a drug that works very well and it's better than TKI. So in second line, we have the resource, which is regorafenib after progression, the radiological progression on sorafenib for patients who had good tolerance for sorafenib. And the data would seem appealing, and this is very good. And it show a difference between placebo and the patient continue on regorafenib, a difference around 3 months. And we come to the multikinase inhibitors. Most significantly, it is a MET inhibitor. It's been tried on the second and the third line. It did show benefit on the over placebo by 2 months. Ramrisamab, Dr. Ali was telling me, you're the only one who believes in Ramrisamab. I think it's an excellent drug in HCC patients, especially if you use it on the right patient. So we know from the clinical trial, initially, it was not significant, but when they look at the patient on the phase 3 of alpha-fetoprotein, more than 400, for these patients, you show a difference between placebo and ramrisamab. And honestly, I have a patient who's been on 1 year on ramrisamab. Also, it's a stable disease, some response, but at least the patient have a benefit in terms of low toxicity profile. So I think the most important, which is a combination of local, regional, and systemic therapy. We know TACE and TARE would show an improvement in overall survival. And now with the advances of the technique, we show good results and probably very good interventional radiology. But I think interventional radiology or local regional therapy alone is not enough. So there's a couple of clinical trials that show either having the systemic therapy with local regional therapy, or even together or sequential have been tried in clinical trial. So let's say what happened in sorafenib. We know from ages sorafenib been tried in different clinical trial using the conventional TACE, the DCP, and there is no overall survival or time to progression. But if you look at this, also this TACE trial, adding with or without sorafenib. So adding sorafenib did not improve the progression-free survival. This is the only trial that show a difference on the progression-free survival, and the difference is almost like we're talking about like 12 months. But I think the one that changed the landscape is not sorafenib plus local regional, it's lenvatinib, which is in this clinical trial. They look adding lenvatinib to TACE on patient with HCC. So patient with advanced HCC, they should have multiple disease, single size, less than 10, or multiple, but they should be less than 10. That means tumor burden less than 50%. Performance status is good. So the patient will receive TACE and lenvatinib. TACE will start in day 1, and the patient will start lenvatinib either 8 and 12 based on the weight. And the second arm will be lenvatinib alone. Primary endpoint, overall survival, secondary PFS, time to progression, and overall response rate. And if you look to the patient who received TACE plus lenvatinib, the overall survival, the difference is 6 months with excellent hazard ratio of 0.4, and also the progression-free survival improved. So I think looking at local regional with any targeted therapy, lenvatinib is the way to go if you think about that. This is looking more to patients who receive lenvatinib and TACE. And if you look also again to that median overall survival on the patient who receive and the patient with the intermediate stage, which is most of the time we think about intermediate stage, this is a case of local regional therapy. So if you think about adding systemic therapy for the intermediate stage, you can achieve good benefit in terms of PFS and overall survival. This is a small trial. They look at giving the systemic therapy upfront, like thinking of it as like semi-neoadjuvant. It's a small trial. It was not a huge number of patients. This is a busy slide. Just to make it short, 44% of the patients who receive atezo-bev, they are downstage from advanced to intermediate, and these patients underwent either local therapy like ablation or TACE. So I think we're gonna hear more about this, but this is not a huge number. But again, if you treat the patient with systemic therapy and the patient achieves a good response, you should think further of local regional therapy. So systemic therapy, we have the combination of the triplet, nivo, AP, and cabozantinib in patient with HCC. If you ask me, are you a big fan of the triplet? I would say no, because of the toxicity, it's inexpensive. And if you look at the numbers for us, does not make a big difference. If you look to the two competitors now, which is the Iron Brave or the Himalaya. We'll start with the Iron Brave because it's come first for patients with locally advanced metastatic HCC, no prior therapy, atezo-bev versus the usual competitor. It is a dinosaur, sorafenib. So the primary endpoint with overall survival. If you look here, the primary endpoint did not reach. And again, PFS was very good, almost 7 months versus 4.3 months. And if you look at safety, it's a very safe drug. Most of us are using these combination, and very much, I think it's less toxic than TKI for sure, lenvatinib or sorafenib. Now we go to the Himalaya. So because I know the question at the end of this session will be Himalaya or Iron Brave, so don't ask me this question, please. So this is looking at the combination of tremi and durvalumab on the first line for unresectable, no prior therapy, or durvalumab as single agent. The most important is the steroid regimen, which they give 1 dose of tremi of 300, and the patient continue in durvalumab. And again, overall survival is the primary endpoint. If you look here at the median overall survival, 16.4 versus 13.8 for sorafenib. And again, if you look at 36 months, still there is a huge difference on both curves continue to separate. 30% for the combination, the steroid regimen versus 20%. And again, if you look to durvalumab as a single agent, we know nivolumab did not beat sorafenib in the head-to-head comparison, but durvalumab did. And it did show a good overall survival, similar to the combination, 16.4 versus 13 for the sorafenib. And again, it did show good separation up to 36 months. Again, at the end of the curve, you can see there is some dip on the durvalumab part. This is looking at the secondary endpoint, which is PFS. Honestly, if you look at the PFS between all the 3 arms, there is no much of difference. Even sorafenib is 4 versus 3.6, 3.7. So the progression-free survival was not really significant. So if we want to summarize what we're doing now, I think every patient comes to the clinic, you should assess the patient if he's a candidate for immunotherapy, which is either durvalumab tremi or atezo-bev. If you want to, if the patient a candidate, you should go ahead. I think the patient would not be candidate for atezo-bev if there is a risk of bleeding. In terms of immunotherapy, they are very much equal. If you choose to start on sorafenib, your second choice will be, again, TKI or cabozantinib or ramresimab. But if you choose to use atezo-bev, there is a good data of TKI in second line, lenvatinib and sorafenib. So that will be, if you ask me personally, which treatment will go at second line, I believe sorafenib, even the data is better for lenvatinib, but I believe sorafenib is less toxic and better drug. Thank you very much.
Thank you very much. Thank you very much, Dr. Ashwaq. I would like to ask our speaker to come to the podium for the questions. Okay. So I will start with one question to Dr. Ali Zahrani. Thank you very much for the nice talk. So I saw the recommendation from the NCCN to do a biopsy before switching the patient to the TDX. I don't see patients with breast cancer, they do the same, they just switch the patient to the lines without repeating the biopsy. So would you recommend to repeat the biopsy before using the TDX in second line setting in patient with gastric cancer?
Thank you. Yeah, this is really a very important question, and the recommendations are really different from one society to the other. For example, the Japanese, they don't recommend. But when you look to the Destiny Gastric 01, they have, I didn't really put, the slide was there, but I just removed it because of time. They have done some sort of subgrouping of those who had tested before the first line, trastuzumab, and those who had tested after. And they checked if there is a difference in response with trastuzumab deruxtecan afterwards. And there was a difference, actually. There was a difference of around 10%, although both of them had responded. So at the end of the day, there is definitely, intratumoral heterogeneity. But sometimes we end up with positive results even after that. Sometimes you don't do that. The problem with rebiopsying is, sometimes it's not pleasant for the patients to do rebiopsy, and the recommendation is to do at least five biopsies. So at the end of the day, the recommendation is really different from one to another. There is another interesting ways to do actually ctDNA. And this is less harmful to the patients, and the concordance with the positivity is really high, more than 80%. And I'm sure it will be the answer in the future. In the trial of tucatinib, they actually put both biopsy of tissue and ctDNA at the same time. And they wanted to know if this is going to be different in terms of response. So I think this is the way to go in the future. But again, personally, I think instead of, trastuzumab deruxtecan is not without toxicity. So I think rebiopsying it is really very important if it is accessible. And this is really my personal recommendation.
If you allow me, Dr. Gurney, a question to Dr. Ali about the same issue. Does it make a difference, like biopsy from primary versus metastatic?
Yes, as you could see in the slides that I bought, you might have some discrepancy. You don't have always the same thing that what's happening in the primary to the metastatic. If you have metastasis all over the body and you don't know which one is the resistant or positive, then the answer is yes. And the recommendation of actually CAP ASCO is to do 10% of the specimen if you have the primary, at least. Although there are some trials showed that if you actually doing it and you have the result more than 40% and the ratio of HER2 to CEP more than 3, this will be the best for response. So if you have widespread metastasis, then and it is accessible, then it is really better to do that. Since you have the bulkiness is the metastasis. But at the end of the day, you don't know. I mean, is it going to be positive for all the metastatic area or negative? So at least if you have positive results, you might have a stronger, evidence to start the anti-HER2.
Thank you.
Ashwat, I have to ask you the question that you don't want to be asked. Luckily, we have so many options now for HCC. I think you very nicely presented all the options that we have. And I want to be the devil's advocate and speak with numbers. And when we talk about Himalaya, we talk about more than 16 months. When we talk about launch, we talk about more than 17 months. When we talk about Embrave 150, we talk about more than 19 months. And when we talk about LEAP, which was unfortunately negative, and Lenva Pembro, we talk more than 20 months. Yeah. How do you rank them? Which patient would you give what? And if you get a BCLC, let's say C patient, child A, no varices, how would you approach?
That's by default, I'll start on atezolizumab. If the patient have no clear indication, contraindication, so I'll start on atezolizumab. Again, PIVA, people think of Avastin and varices. No, there is too many things beyond that. Patient post-biopsy, they will have a bleeder. We have a couple of patients like this. Patient with severe coronary disease post-stent, they are on antiplatelet, just fresh. I wouldn't start patient on Avastin. So that will be for the other combination, which is Dorbertremi, if I have the drug on hand. For single agent, if I cannot give dual therapy, single agent, we have durvalumab and nivolumab. That's 2 drugs. Pembrolizumab have been used a lot on the RCC. The result is extremely good, yet I haven't used it on HCC. And again, lenvatinib is a single agent. It's very toxic. So if, again, I'd come to me to choose between TKI, I think the 2 drugs that I see less toxic, sorafenib and cabozantinib, which is I learned a lot from the RCCs, not yet in the HCC. So atezolizumab.
In upcoming clinical trials, would you still be happy to see sorafenib as the competitor arm? And when with Pembra Lenva, we saw that they chose lenvatinib as the competitor arm, and it really it gave a superb result, resulting in the non-superiority of lenvatinib and pembrolizumab. How would you want to see new upcoming trials in HCC?
I think it makes sense, like if they are giving pembrolizumab to compare with lenvatinib, not sorafenib. But I believe it is the best TKI therapy available in the first line setting, and even post immunotherapy. I use sorafenib post immunotherapy on these patients. I think lenvatinib is a good drug, but probably our patient is very fragile and toxicity profile is extremely high. I said I did not use it. No, I used lenvatinib in a couple of patients for the last few months, and I'm not happy.
Thank you, Ashwa.
So I have a question to Dr. Ahmed Al-Shehri. You did a very nice work trying to show us the biomarkers and therapy, but for me, it's always confusing the gastric cancer with all these scores and these indicators. So my question, Dr. Ahmed, so for MSI high, what would be your preferred option? Do you think chemo has a part on those population? Would you think dual immunotherapy is the way to go, or single agent pembrolizumab?
Excellent. Thank you, Dr. Muhammad. When we talk about MSI high gastroesophageal, first of all, gastric cancer is a different entity than esophageal cancer. When we talk about MSI high gastric cancer, I would prefer to use the least toxic treatment that will give me the maximum clinical benefit. In such case, I might prefer to use pembrolizumab, okay, based on the Keynote 062 study, which showed that Pempro, as opposed to chemotherapy, showed a superb kind of outcome. Yes, the nivolumab chemotherapy did show also significant improvement as compared to chemotherapy, but I mean, the chemotherapy is a bit kind of toxic kind of regimen. So if you want to choose the treatment that will give you the best outcome with the least toxicity, I would go with Pempro as a monotherapy in gastric cancer. Remember, the dual immunotherapy in gastric cancer, that arm was closed because of toxicity. And I think the problem with that was the dosing they used of the immunotherapy. They used 3 milligram of ipilimumab and 1 milligram of nivolumab. And this is why it was very toxic and was closed. We'll take that to the esophageal cancer. Esophageal cancer, if we're talking about dual immunotherapy, the dosing is a bit different. I mean, they use 1 milligram of ipilimumab, 3 milligram of nivolumab. And that kind of dual immunotherapy will be my choice if I want to go with the least toxic regimen in MSI high esophageal cancer. This would be my choice actually in these patients. To sum up, if I have MSI high patients, I would choose to go for Pempro and gastric cancer. I chose to go with dual immunotherapy or Pempro as a monotherapy in MSI high esophageal cancer. Unless the response rate is needed, then I might consider the Nivo and chemotherapy.
No, I couldn't.
So I have a last question to Mohammed. You have shown a very good, example of personalized medicine, which is the biliary tract cancer. The main issue now is getting this medication on time. So you have the results, you request the medication, but unfortunately, most of the time they don't come. So what other active systemic chemotherapy that you might use beyond the first and second line if you still have a patient who cannot have an access to this medication? Because this is a common scenario that most of us will end up with.
Thank you very much. Thank you very much, Mohammed. That's an excellent question. So if you still have a patient who has a good performance status and fit for treatment, and progressed on the standard of care of cisgem and then FOLFOX, you could always try irinotecan as a single agent if the liver enzymes allows you to go for. You could use it in the combination of 5FU also. However, I think that's always the story in such diseases. I mean, you start with nothing, but you have a lot of options, and then with time, these options will be eventually available, and if it is even for a limited number of patients, but that's what we have to live with and used to do.
Sure. So thank you all for excellent discussion, and thanks everyone for listening. So I think we have a break now until 11, and we'll be back for session 2. Thank you.
Right. Assalamu alaikum. Good morning, everybody, and welcome to our fourth session of this symposium. First, I would like to thank the organizing and scientific committee for organizing this great meeting. So this session will be a mixture of many topics, including molecular, precision oncology, genetics, and also palliative care. Without further ado, I would like to introduce our first speaker, Dr. Kanaan Al-Shammari, who is well known to all of us, consultant medical oncologist at King Abdulaziz Medical City, National Guard Hospital in Riyadh. He is director of MENA NCCN Regional Coordinator Center. He has also done a lot of training in GI, sarcoma, and phase 1 oncology. His topic today will be the role of circulating tumor DNA in early colorectal cancer. Dr. Kanaan, the mic is yours.
Thank you, Dr. Ali. Thank you, Dr. Waleed. And I also thank Dr. Mohammed Al-Garni and Dr. Ashwaq Al-Alayan. So I'll share some background evidence, then we'll jump deep into the evidence and the new updates regarding liquid biopsy in early colorectal cancer. So in early colorectal cancer, we know that stage 2, the optimal management remains surgery, and surgery alone cures more than 80% of all patients. There is always debate about what's the magnitude of benefit for adjuvant chemotherapy. And when we consider adjuvant chemotherapy, we look at clinical pathological characteristics that determine whether we give adjuvant chemo or not. And these have not changed over the last probably 15 to 20 years. And there is some variability with regards to high-risk features between the guidelines. Not all high-risk features are equal. A recent publication, I think that came at least 2 or 3 years ago, spoke about pathological T4 being the worst prognosis with regards to recurrence rates. And survival benefit remains very modest with adjuvant chemotherapy in high-risk patients. And we always quote 4 to 5% maximum. So a better, precise prediction for recurrence risk is definitely needed. So MRD, or minimal residual disease, this has been probably exhausted with our colleagues in malignant hematology. We are starting to learn more about it now in solid tumors. And ctDNA does detect MRD in solid tumors. But ctDNA detection after curative intent surgery, including stage 2 colon cancer, does predict a high recurrence risk. And the benefit of adjuvant chemotherapy in ctDNA positive patients is unknown. So the dynamic study, which I'm going to explain later, is designed to investigate whether liquid biopsy, testing specifically for ctDNA, guided approach against the standard approach, looking at clinical pathological characteristics, actually does benefit or does not compromise the recurrence risk. So a very quick background on MRD, an older trial, dating back to even 2016, took 250 stage 2 colon cancer cases after curative intent surgery. And at a certain time point, they took their plasma and they looked for circulating tumor DNA. Patients with positive ctDNA, labeled as MRD positive, had a much higher risk of recurrence compared to ones who have had no circulating tumor DNA. Also, other studies have also examined this in stages 1 to 3, and they looked at different markers. Genitourinary in Australia looked at SafeSeq testing, and others have looked at Signatera testing. All of them concluded that if you have ctDNA positivity after curative resection, the chances of recurrence are up to 18 times higher compared to ctDNA negative after surgery. What I wanted to show you here is the huge variability in detection rate. It ranges from 5% up to 21%. And all of this really depends on testing. So different modalities of testing will definitely give you different detection rates. I explained to you post-curative surgery ctDNA assay. This is post-chemotherapy, post-adjuvant chemotherapy ctDNA. This is also prognostic, meaning after you give adjuvant chemotherapy, if your plasma or liquid biopsy positive for ctDNA, your 3-year relapse-free survival drops significantly to 30%. And these two studies also confirm this same finding. So back to our dynamic study. So they took stage 2, and this is great because this is where the debate is. So they took stage 2, and what they did is at week 4 and at week 7, they took 2 blood samples where they tested for ctDNA. If the patient was ctDNA positive, they gave adjuvant chemotherapy. If the patient was ctDNA negative, they observed the patient. And this is regardless of high risk or low risk features. Standard management is, as we have been practicing for the last 15 years, one of the high risk features, which is less than 12 lymph nodes tested, T4, perforation, and others, they decided whether to give adjuvant chemo or not. The endpoint was relapse-free survival rate at 2 years and the difference between the two groups. And their ctDNA was quite unique, and hence I'm presenting this slide. They took a sample from the primary resected tumor. They tested it for 15 genes that are known to be mutated in colorectal cancer, such as APC, TP53, KRAS, PIK3CA, BRAF, SMAD4, HRAS, HER3, and others. And at week 4 and week 7, they took 2 samples, and they looked specifically for these mutations in the plasma. If one of these mutations is found in the plasma, most likely this is positive ctDNA that originated from the patient's tumor. Statistical considerations, patients eligible who were randomized and had both blood draws, so at week 4 and week 7, and the primary analysis when the last patient reached a minimum follow-up of 2 years. And what they wanted to see is non-inferiority at 2 years with a margin of 8.5%. And if there is a difference more than 8.5%, most likely it is inferior. So we're going to see the results soon. So subject disposition, there was 2-to-1 randomization for CT-guided management, and the end result resulted in almost 290 patients receiving ctDNA-guided management versus almost 150 receiving standard management. Baseline characteristics, most of these were excellent performance status. Most of them actually were T3, not T4. Less than 12 lymph nodes removed was very few, 4-5%. LVI present was almost 1/4 of patients, and clinical risk group high, these are the patients that we routinely give adjuvant chemotherapy for, were 40% in both groups. Now, adjuvant therapy delivered in ctDNA guided was 15%, and in standard therapy was almost 30%, yani double that in the standard therapy. Chemotherapy given was mostly oxaliplatin based, and this is very important here, and this is what we should focus on. Time from surgery to commencing chemotherapy. The median here is 83 days. And we know from our older trials that the longer time from surgery till delivery of chemotherapy, that benefit of adjuvant chemotherapy drops. So here, the median time is 83, most likely because they had to wait for the results of week 7 ctDNA sample, whereas in conventional group, 53, that is significantly less, almost a month less. Most patients completed therapy. So in terms of adjuvant therapy delivered in key subgroups, so most of the T4 therapies received adjuvant chemotherapy based on standard management, and less than half of those were actually ctDNA negative, so they did not receive adjuvant chemotherapy. So this is just exciting everyone to show you the result. Does this actually work or not? and poorly differentiated histology, most of them received adjuvant chemotherapy, whereas only a few of them received adjuvant chemotherapy. So the majority of them were actually ctDNA negative. Like this is what the study is all about. And if someone can tell me that there's a big difference between these two arms, I would, I don't know what I'm going to do, but there's definitely no big difference between the two arms. They are almost identical. And the difference was less than 4%. So negligible difference. And we'll see what is superior soon. So the recurrence-free survival in the subgroups, the benefit, the majority of benefit was actually for the T4 patients. It was favoring ctDNA guided therapy. So a lot of the time, we may actually be giving our T4 patients adjuvant chemotherapy based on clinical pathological characteristics where they may not have needed it based on ctDNA. And the other one was a low ctDNA or a low clinical pathological risk. And the other one is poorly differentiated histology. Now, recurrence-free survival based on ctDNA guided management. So all of these were tested for ctDNA and they were randomized and given therapy based on ctDNA. If you are negative, your survival at 36 months was more than 93%. And if you are positive and given chemotherapy, your survival is not extremely different. The difference is probably around 7%, and it ranges up to 86.4%. Now, with regards to clinical risk and T stage, if your ctDNA is negative and you are low risk, survival is up to 97% at 36 months, which is great. If you are T4 and ctDNA negative, up to 94%. And this is unlike what we know from just purely basing the risk stratification based on the clinical pathological risk. And if you are T4 and you received, your ctDNA was positive and you were treated, your survival is 81.3%, which is still decent. So in summary, for patients with stage 2 colon cancer, the ctDNA guided approach, so treating only patients with a positive ctDNA after surgery compared to standard of care, did reduce the proportion of patients receiving adjuvant chemotherapy and did not compromise recurrence-free survival. Patients with positive ctDNA after surgery may derive a maximal benefit from adjuvant chemotherapy. And there was a favorable 3-year relapse-free survival in patients with adjuvant chemotherapy versus low relapse-free survival in historical series, if untreated. There are many ongoing trials, which I'll skim through very quickly, that will provide further guidance regarding the optimal use of ctDNA-informed management. And ctDNA negative patients have a very low risk of recurrence without even adjuvant chemotherapy, regardless of whether they were clinical pathologically high risk or not high risk. And this study, the dynamic study, was actually published in New England Journal of Medicine and was available in December of actually 2 months ago. And this is a summary of the endpoints here. So what I want to show you here is the 2-year relapse-free survival. If you are ctDNA guided, your 2-year relapse-free survival was actually higher compared to when you were treated on standard approach. So basing your risk based on clinical pathological characterization. And chemo use was half of that in standard compared to ctDNA guided. So we gave significantly lower chemotherapy and the survival was actually higher. So this is exactly what we wanted to see. And this is what ctDNA in early colorectal cancer is all about. Now this here summarizes the many studies that are upcoming. And a COBRA study is actually looking also at lower risk stage 2. However, they're using the Guardant Lunar 1, which we know Guardant are the leaders in liquid biopsy technology. Now, as you can see, a lot of these have different assays, and different assays have different detection rates and so forth. But this is very exciting. I think over the next 3 years, most likely we are going to base giving adjuvant chemotherapy, most likely based on ctDNA positivity or not. And by this, I conclude. Thank you for listening.
Thank you, Dr. Kanan, for the excellent presentation. And I think with this, we'll leave the question for the end. We can proceed to the second talk, which will be about palliative care and GI cancers. It will be presented by Dr. Ahmed bin Ahmed, who is a consultant, palliative care and family medicine at King Abdulaziz Medical City. And he's the program director of palliative medicine fellowship at King Abdulaziz Medical City. Looking forward to your talk, Dr. Ahmed.
شكرا جزيلا. السلام عليكم. Today we're going to talk about palliative care in GI cancers. So first we will talk about cancer global aspects. Around 19.3 million new cancer cases and around 10 million cancer deaths worldwide. By 2040, the global burden is expected to grow to 27.5 million new cancer cases and around 16.3 million cancer deaths. The future burden will probably be even larger due to increasing prevalence of factors that increase risk, such as smoking, unhealthy diet, and physical inactivity. So the change in three measures of cancer mortality is increasing by from 19 to 90 to 2019 is increasing. This doesn't affect the survival. The question is cancer survival rate increasing? Yes. In the United States, there has been an increase in the 5-year relative survival rate between people diagnosed with cancer between 1975 to 1977 and people diagnosed with cancer in 2007, 2013, with decrease in cancer mortality to around 20%. So in UK also, the survival of cancer is improving from 24% to 50% in the last 40 years, with a huge variation in survival between cancer types. So the global cancer survival and cure rate, receiving the best available treatment for all. In high-income countries, the 5-year survival is 55%. Where the world average is 35%, and in low-income countries is 20%. So what is palliative care? If we're going to take a brief about the introduction of palliative care, it came from the clock, which is covered, al-wishah bil-Arabi, which is covering the whole body of the patient and person. So it's a medical care that focuses on alleviating the intensity of symptoms of disease. Palliative care focuses on reducing the prominence and severity of symptoms. The World Health Organization describes it as an approach that improves the quality of life for patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment of treatment of pain and other problems physically and so psychosocial and spiritual. So what is the concept of palliative? It's to provide relief from pain and other distressing symptoms, frame life and regards dying as a normal process, intend neither to hasten and postpone death, integrate the psychological and spiritual aspect of patient care, offer a support system to help patients live as actively as possible until death. Offers a support system to help the family cope during patient illness and their own bereavement. Use a team approach to address the needs of patients and their families, including bereavement, counseling, and if indicated, will enhance quality of life and may also positively influence the course of illness. Is applicable early in the course of illness in conjunction with other therapies that intended to prolong life, such as chemotherapy or radiation therapy, and include those investigations needed to better understanding and manage distressing clinical complications. So the goal is to improve the quality of life for individuals who are suffering from severe disease. Palliative care offers a diverse array of assistance and care to the patient. The focus of our care is the patient and his family. This is the multidisciplinary team. It's a physician, nursing, social worker, PT, OT, dietitian, and others. And we are aiming to treat the total suffering patient physically, spiritually, socially, and psychosocial. So what is the right model of palliative care? Previously, there was an active treatment intending to cure. Then after it stopped, it came to palliative care until death. Now, palliative care introduced early with intent to cure. When the intent to cure or life prolonging is decreasing, the palliative or comfort intent is increasing until death, then there is a treatment. So cancer and palliative care. In general, estimated that roughly 7.2 to 7.5 million people worldwide die from cancer each year. More than 70% of all cancer deaths in developing countries. Their resources available for prevention, diagnosis, and treatment of cancer are limited or non-existent. More than 40% of all cancer can be prevented. Other can be detected early, treated, and cured, even with late-stage cancer. The suffering of patients can be relieved by good palliative care. Palliative care is given throughout a patient experience with cancer. Care can begin at diagnosis and continue through treatment, follow-up care, and end of life. So everyone has the right to be treated and die with dignity. The relief of pain, physical, emotional, spiritual, and social, is a human right. Palliative care is an urgent need worldwide for people living with advanced stage of cancer, particularly in the developing country, where a high proportion of people with cancer are diagnosed when treatment is no longer effective. So if we go to GI malignancy and palliative care, gastrointestinal malignancy cancer accounted around 17% of the 20 million estimated new cancer cases. The various GI cancer, although arising from anatomically adjacent organ, have different symptoms and pattern of prognosis. Palliative strategies are therefore tailored to the complication caused by the particular combination of local invasion and distant spread of tumors arising from a given site of organ. So what is the common symptoms in GI cancer? It's pain, bleeding, malignant bowel obstruction, nausea and vomiting, anorexia, cachexia syndrome, ascites, constipation, psychosocial issues, and decreased quality of life. Managing symptoms during the GI cancer is critical, particularly near the end of life when symptoms burden escalated. Patients with GI cancer reported a variety of symptoms throughout the disease process, with the nature of severity of symptoms depending on type of cancer and proximity to death. Uncontrolled symptoms often lead to patient and caregiver distress and contribute to increased healthcare utilization, such as inpatient hospitalization and ER department visits. To address cancer-related symptoms, care providers require accurate and reliable method to identify such symptoms. The Edmonton Symptoms Assessment Scale, ESAS, is reliable and validated symptom screening tool that is available in several languages and has been used widely in cancer patients. This tool allows patient reporting of symptoms directly to clinician while in hospital, clinics, or also from home. This is an example of Edmonton Symptom Scale ESAS. It's a neuromic scale for from 0 to 10 for pain, fatigue, drowsiness, nausea, and lack of appetite, shortness of breath, depression, and anxiety, and best well-being. So patients with GI cancer have high symptoms burden and healthcare utilization at the end of life, including hospitalization and subsequent death of the hospital. Studies measures the GI cancer death and describe the symptoms profile, determine the effect of outpatient palliative care initiation on symptoms burden in patients with GI cancer in a final year of life. So they collect around 11,242 cancer deaths from GI cancers. As we saw that by time the suffering is increasing, the main domains are lack of appetite, fatigue, and pain. This study shows that symptom score increase in those with no mild symptoms. This increase was statistically significant in all domains, but clinically significant in only a few domains. This is consistent with a previous report show exacerbation of symptoms in cancer patients with none or mild symptoms after an outpatient palliative care encounter. This may be because symptom score is in all domain increase close to death, or that is intervention may only be effective when symptoms reach a certain severity level. So let's take some of the common symptoms of cancer, of GI cancer, and talk about it. First one is pain. Pain is a very high percentage in all cancer type. It's around 70 to 80 in GI cancer. For many people, the fear of cancer is the fear of pain. So the good news that cancer pain is treatable, but the bad news is still undertreated. 80% of cancer patients have no access to pain relieving drug required. The WHO has demonstrated that most, around 75 to 85 of cancer pain can be relieved if we implement an available pharmacological approach that is inexpensive and yet a practical one. So freedom from pain should be seen as a right for every cancer patient, and access to pain therapy is a measure of respect to this right. For example, 37% of inpatient are undertreated. Around 30% of patients with moderate to severe pain have no opioid. 7% of those have no analgesia at all. So what is the cause of cancer pain? Disease-related, 78%, treatment-related, 19%, and the related to other comorbidities is 3%. So this is the WHO ladder, analgesic ladder. We should use it for pain control. Step 1, we are using non-opioid drugs as paracetamol or non-steroidal anti-inflammatory drug. Second step is the weak opioid as codeine or tramadol, plus minus non-opioid or adjuvant therapy. Step 3, for severe pain, we use strong opioid as morphine, hydromorphone, oxycodone, fentanyl, and methadone, plus minus non-opioid and or adjuvant therapy. So general principle in pain treatment, always we prefer oral route, always by clock, don't use TID or BID, by the ladder. For each individual has his need for pain treatment, with attention to details, and have low prescription threshold, please. Always start low, go slow, but please do so. We use adjuvant drug if needed. Educate patient about possible side effect. So if you prescribe these opioid, always remember to prescribe laxatives. Educate patient about temporary side effect as drowsiness and nausea and vomiting. The other common symptoms we are going to talk about is malignant bowel obstruction. GI malignancy are common and deadly. The most recent survival epidemiology and end result program data indicate that colorectal cancer, pancreatic cancer, and esophageal cancer are the 2nd, 3rd, and 11th leading cause of cancer-related death in the United States. Most symptoms from GI malignancy relate to obstruction at their primary tumor site. The predominant intervention to palliative malignant obstruction were previously surgical. Surgical procedure carry significant morbidity and mortality, particularly for patients with advanced disease. Given the risk of surgical approach for palliation, advanced endoscopic procedures such as ERCP and biliary or internal stenting have now moved to the forefront in palliation of advanced disease. Malignant inoperable bowel obstruction is most often caused by presence of peritoneum carcinomatosis. It is the most serious complication of colorectal cancer or GI cancer in general. The global prevalence of malignant bowel obstruction is estimated to be 10 to 28% in people with GI cancers. Median survival after its onset range from 30 to 90 days. Require high individualized approach tailored to the patient medical condition, prognosis, and goal of care. Surgery as palliation is rarely indicated. Less invasive approach such as gastric or colonic stenting are useful. Nasogastric tube is, if required, should be used only temporary measure. Medical measures such as analgesics, anti-security drugs, and antiemetic are highly effective in relieving distressing obstruction symptoms. Venting tube should be considered if drug failed to reduce vomiting to an acceptable level. TBN is rarely and mostly not indicated in such advanced cancer. Parenteral hydration is almost not required in advanced end-stage malignancy. A collaborative approach can offer patient an individualized and appropriate symptom management plan. Third, the symptoms we're going to talk about is anorexia cachexia syndrome for cancer, GI cancer. A primary anorexia and cachexia syndrome result from hypermetabolic state caused directly by the cancer, mediated by tumor-associated cytokinase, change in metabolism. The secondary cause result from cancer-related barriers, as cancer-related GI obstruction, nausea, vomiting, and mucositis. The primary goal of nutrition and hydration in terminally ill and is comfort, improving quality of life by giving the patient maximum enjoyment from eating. Traditional goal of balanced diet and achieving an ideal weight are not realistic or appropriate in the stage of life. When a person with advanced disease or in terminal illness stop eating, usually it is because disease has progressed to the point there where the person is no longer able to process food and fluid as does healthy person. Forcing this person to eat or starting artificial nutrition and hydration does not help the person to live longer, feel better, feel stronger, or be able to do more. Artificial nutrition and hydration will often proceed bloating, nausea, or diarrhea and decrease quality of life. The majority of dying patients never experience hunger, and in those who do, pleasure feed relieve the hunger. So all human beings are born free and equal dignity and equal in dignity and rights. We are as a palliative care physician focus on relieving their suffering, improving quality of life, to live and die with dignity and respect, care for patient and his family. So the take-home message, palliative care is most effective when patients are referred early at the time of their diagnosis to improve quality of life. A better understanding of what is palliative care and how it improve outcome can encourage early referral and reduce unnecessarily physical, emotional, and financial suffering. So please, end-of-life care of a huge burden. It needs more than one shoulder. Please let us help anytime and in early stage. Thank you.
Thank you very much, Dr. Ahmed, for this comprehensive summary of palliative care and more concentration of GI cancer. We will leave the questions to the end of the session. Now I would like to invite our next speaker, Dr. Mohammed Al-Garni. He is a consultant medical oncologist at King Abdulaziz Medical City National Guard Hospital in Riyadh. He is also the section head of Cancer Control and Outreach Division and the director of Medical Oncology Program Fellowship. Today he will talk about genetic syndromes and GI cancer. Dr. Mohammed Al-Garni, the mic is yours.
Thank you very much, Ali, for the kind introduction. So my task is to talk about genetic syndrome and GI cancer, which is relatively a big topic. So I will try to focus on certain aspects of the association between genetic and GI cancer. So in general, why we need genetic testing or germline genetic testing in oncology clinic. This helps us in providing a personalized cancer risk assessment. It has a role in as predictive and prognostic tool, definitely for prevention and screening, which we are aiming for, and therapeutic intervention that can be surgical or medical, depending on the result that we have. So we'll go over a certain type of cancer, the GI tract, and the association with genetic syndrome, starting with pancreatic cancer. So it has been shown before that in different population with different cohort of patients, that doing genetic testing for all patients with pancreatic cancer associated with yield of higher yield of identifying patients who carry germline mutation compared to just sticking to the screening or testing guidelines. These are two large studies that raise this concept. One of them, they used 32 gene, the other one used limited also gene panel, and they found that about 3.9%, we're talking about 4% of all patients with pancreatic cancer, they have genetic mutation. The other study showed higher prevalence of this mutation, which about 13.5%. So the variation that we see is related to different population that we have studied. And this has been also looked at larger cohort of patients in Memorial Sloan Kettering Cancer Center. They used more than 400 gene, and they showed the same, that about 8% of patients carry germline mutation in BRCA1 and BRCA2, which is the commonest, with high prevalence in Ashkenazi Jewish population, which is well established. And there is another 4% of other gene associated with pancreatic cancer. And the interesting thing in this study that they found almost 40% of patients, they did not meet the current testing guideline. So this enhanced the role of doing genetic testing for all patients with pancreatic cancer. Also, we looked to this in our population, and this was presented a year ago at the ASCO GI. We looked into more than 80 patients with pancreatic ductal carcinoma without any identifiable family history, and we tested them with more than 70 gene panel. And we found that in our population, about 8% of patients carry pathogenic germline mutation. So it's matching the general population. These are the genes that is reported in our population. The most common is BRCA2, followed by other gene. So the role of doing genetic testing in pancreatic cancer has not only established for cancer prevention or screening for family, but also it has a therapeutic implication. This is the POLO trial that looked to the role of olaparib in patients with germline mutation in BRCA mutant metastatic pancreatic cancer. It showed that this improved the progression-free survival. However, this was not transferred into overall survival benefit. However, it established the role of olaparib as an option, as a maintenance therapy in patients with metastatic pancreatic cancer related to BRCA mutation. Also, we learned that it goes beyond only BRCA1 and BRCA2. Now we have the homologous recombination pathway. And we know that homologous recombination deficiency, which encompass different genes, including BRCA1 and BRCA2, predict the response to platinum-based chemotherapy. And if you look to this study, that some of them, not only in pancreatic, but also for ovarian, those who receive platinum-based chemotherapy, they have a better outcome if they are HRD deficient. And if you look to this study that was done specifically in patients with pancreatic cancer, you find using cisplatin gemcitabine, which is relatively less toxic compared to FOLFIRINOX in patients with pancreatic cancer, has resulted in unreported before response rate, which is 74% response rate in patients with pancreatic cancer. So this indicates that you might use this regimen as a systemic therapy, cisplatin gemcitabine in patient with germline BRCA mutation. Now, this established the role of testing all patients with pancreatic cancer for hereditary cancer syndrome. Now we'll move to hereditary gastric cancer syndromes. There are multiple syndromes associated with hereditary gastric cancer. The most well-established and understood is the hereditary diffuse gastric cancer, which is related to CDH1. And there are other multiple genetic syndrome that is associated with this, including Lynch syndrome, BJS syndrome, and others. So one of the important gene that has been also studied in patients with gastric cancer or increase the risk of gastric cancer is the APC gene. And as you can see on this gene, which is the gene responsible on about familial adenomatous polyposis, you can get different form of syndrome depending on the location of the mutation. So we have the classical FAB, which is the severe FAB that associated with high risk of colon cancer. Then we have the attenuated FAB, which is related to late onset colon and stomach cancer with less number of polyps associated with this compared to the severe FAB. And we have a rare entity, but it's well described, which is the gastric adenocarcinoma with proximal polyposis syndrome, where you have only polyps formed in the stomach, and it's increased the risk of gastric cancer. So depending on the gene mutation, you can have different phenotype, which means different treatment and different screening recommendation. Hereditary diffuse gastric cancer, as I mentioned, is the commonest one. It's run in a autosomal dominant pattern. It increased the lifetime risk about 70 to 80%, and it's also associated with familial lobular breast cancer. The other hereditary diffuse gastric cancer gene, which is less common, is the CTNNA1, which is also run in an autosomal dominant. It's usually associated with diffuse gastric cancer. The establishment of the lifetime risk has not been identified, and there is no described association with the breast cancer or other cancer syndrome. There is a new entity also, which is the familial intestinal gastric cancer. The gene responsible for this is not yet established, and also it has an autosomal dominant that is associated with intestinal type gastric cancer. So this is what we have to do for patient with CDH1 germline mutation. I prefer for our patient to go risk reduction gastrectomy because the surveillance has a lot of controversy. It has to be done by an expert endoscopist who had to do more than 30 biopsies with each time they do the screening because those tumors tend not to form a mass lesion that can be easily biopsied. And instead, it goes submucosa, so sometimes it's difficult to find. For patient, for the prevention of lobular carcinoma, screening is efficient sometimes. And for certain patient with family history, you might consider prophylactic mastectomy. Also, we learned over the last 2 years that even for cancer that we think that is usually not associated with hereditary syndrome, like esophageal cancer, 2 publications last year showed that even patients with esophageal cancer, they are at the risk of hereditary cancer syndrome. And interestingly, the most common gene was reported is the ATM gene, which is a part of homologous recombination deficiency pathway, which would explain to some extent the nice response that we get sometime to platinum-based chemotherapy on patients with esophageal and gastric cancer. Now moving to the commonest referral that we get in the clinic, which is related to colon cancer. So are the typical referral to cancer genetic, mostly breast and colon, and simply because they are the commonest cancer that we see in practice. And also it's the commonest cancer associated with hereditary cancer syndrome. This study also published last year, and they looked for all comer with colon cancer, and they did genetic testing for those patients. They examined more than 360 patients with 80 gene panel, and they found about 56 individual of them, about 15% of the cohort, they have moderate to high penetrant gene, which means that they have a gene that is associated with moderate to high risk of developing cancer. And the most predictive to have a positive genetic testing was diagnosing colon cancer in patients less than 50 years of age. And if you look to the outcome of this, about 11% of those patients, they have modification in their treatment based on the genetic findings. So it has really an important role in managing the patient, not only for cancer screening or prevention. So this is how we look in general to patients with hereditary cancer syndrome. It's depends on whether there is a polyps or no. And when we say hereditary non-polyposis, it does not necessarily mean that those individuals, they do not form polyps, but it's not the most dominant feature. And if we have non-polyposis, we go whether they are mismatch repair deficient or proficient. And for polyposis, we're gonna discuss them as well. So different syndrome, different mode of inheritance. Actually, most of them, they are autosomal dominant apart from the multi-associated polyposis. However, if you have someone with biallelic mutation and multi-associated polyposis, their lifetime risk is really high compared to those who have only heterozygous mutation in multi, which is about 10%. So as you can see here, the wide range and different colorectal cancer risk during their lifetime. So our recommendation variable depend on how the risk of these individuals. For patient with Lynch syndrome, which is the most common established syndrome, we used to use certain criteria like Amsterdam criteria or BSADA criteria to screen the patient. We have also risk assessment model like PREM and MMR predict. But we know with time that even if we do and utilize these tools, we are missing about 50% of patients with Lynch syndrome. So now it has been established that you have to test all patients with colorectal cancer for Lynch syndrome. It has two main aim. One of them is to guide your therapy for patient. It helps you in the decision-making for stage 2 colon cancer, and it helps you understand of care actually for patients with metastatic colon cancer to see if they are a candidate for immunotherapy. And the second aim is to, if they are carrying a germline mutation, you need to do certain risk reduction intervention for the patient and for the family. So the recommendation is to do Lynch syndrome screening for all patients diagnosed with colon cancer. Now, this is the NCCN version of 2018. It's now completely changed. As you can see here, they lumped all the gene together, the MLH1, MSH2, MSH6, and PMS2. And as you can see here, different type of cancer with different lifetime cancer risk. Nowadays, each one of these genes has its own description. It has its own screening guideline and recommendation. So Lynch syndrome, there is no one size that can fit all the individual carry this mutation. And these are the common cancer associated with the Lynch syndrome. And in general, we individualize our recommendation based on the family history and based on which gene is which mismatch repair is deficient. So endometrial and ovarian cancer is a huge risk for women patient with carrying Lynch syndrome gene. Colon cancer definitely is also a major thing. The stomach, brain, skin, urinary tract, and others are also associated with Lynch syndrome. However, it's less risk compared to the colon and the endometrium. So the bottom line that we cannot recommend a general recommendation for all patients with Lynch syndrome. It has to be individualized and it has to be personalized based on their gene mutation. Now, for polyposis, sometimes it's really difficult to diagnose them or have a specific diagnosis, but we goes by definition. So for adenomatous polyposis, if you have more than 10 polyps, juvenile polyposis more 5 or more juvenile polyps, and the list goes on. And we don't only rely on just the histological finding. Also, we need to know the extraintestinal manifestation and the family history, because this will guide us to know what's exactly polyposis syndrome we are dealing with. These are some of the common extraintestinal manifestations that we see in patients with polyposis syndrome, and general examination is a part in the clinic that we do for patients with expected polyposis syndrome, looking for these benign findings. This also some summary of the extraintestinal malignancy that we see in patients with polyposis syndrome. You can see breast cancer is there, ovarian cancer, endometrial cancer, and even brain tumor is associated with certain type of polyposis syndrome. So we are understanding more and more about polyposis syndrome. So this is in 2001. We know that half of patients with polyposis syndrome, they are related to APC gene. But since that time, we start to know more about this. And this is the classification in 2016. We know there are multiple genes associated with polyposis syndrome. Some of them, they are dominant, like the polymerase proofreading associated polyposis. So this is something that you can, for the oncologist, is important, because if you have a patient with high tumor mutation burden or a microsatellite unstable with the presence of all mismatch repair gene, you have to check for poor or pooled one, because this is maybe the reason, and those patients usually respond nicely to immunotherapy. The MAP associated polyposis, we already went over it. And the last thing is the constitutional mismatch repair deficiency, which is a very rare entity of or subtypes of Lynch syndrome, usually associated with cancer in younger population with unusual type of malignancy. So I have one patient, she's 11-year-old with colon cancer. And we have another young woman, she's only 20 and with high-grade ovarian cancer. So usually they present at younger age, and usually there is a consanguinity in the family, which is common in our population. So again, back to some of the basics. So remember, genetic testing sometimes not available everywhere. But again, simple thing that you can do in the clinic is by family history. So presence of family history is very important. So if you can see the three curves, the one in the top, the dots one is those individuals with more than 2 first-degree relative with cancer. And the one in the middle is the one with 1 first-degree relative. And as you can see, the risk increase with time. So they have substantial risk. You have substantial risk if there is a 2 first-degree relative with colon cancer, and hence those population can be easily tackled with intensive screening program through the gastro clinic. So just to wrap up, I think genetic assessment is an important part of comprehensive cancer care for GI cancer patient. The universal testing has been established already for certain GI cancer. The identification of these germline mutations allows us to provide a personalized cancer care for our patient. And it's really recommended to have a cancer genetic program in large cancer center. And by this, I conclude, and thank you very much.
Thank you, Dr. Mohammed. And kindly, I would like to ask the speakers of the session to come to the podium to open the floor for questions. So I would like to start the questions with a question to our first speaker, Dr. Kanan Shamri. So regarding circulating tumor DNA, like you mentioned earlier, we have been hearing about them for the last almost 10 years, and still we don't have a clear answer when to incorporate it in our guideline or not. We have different assays, different trial design, doing it at 4 and 7 weeks, as you mentioned. So what should we expect next over the next few years? Like different design of the trial, or different population, or different assays, or?
Thank you very much, Waleed. A very important question indeed. So I guess what I'm expecting over the next few years is a single solid assay that would be commercially available. And I think the indication now clearly as per dynamic trial, which showed non-inferiority of treating patients on ctDNA and reducing the number of patients significantly by half almost that are exposed to chemotherapy, that have had good long-term survival. So I'm expecting most likely this to be more clear in stage 2. And I hope that we're going to have a commercially available assay that we are able to use. That's what I hope for, inshallah.
Okay, any question from the podium or the chat box? Okay, so while waiting for that, I would like to ask Dr. Ahmed. Many of us are oncologists, are seeing patients who are in pain, and we commonly prescribe the pain treatment from the clinic. So what's your recommendation regarding this? So do we start the treatment and send the patient to palliative, or just send the patient directly to the palliative team? What do you think about this?
Okay, thank you for the question. First step is to start the pain medication by the WHO ladder with the non-opioid, then after that weak opioid, then strong opioid. It's depend on the severity of the pain. If the patient came with severe pain, you can jump to step 3 or 2 directly. And until we see, we can start as a PRN or as needed, low dose, and you send him to our clinic so we can titrate very fast until we control his pain. And please don't forget to add laxative every time you prescribe opioid. Thank you.
Thank you very much.
So another question to Dr. Ahmed, sorry about that. So we have many patients, like especially with hepatobiliary cancer or any patient with metastatic disease to the hepatobiliary system, sometimes when they run out of their systemic treatment option and decided for supportive care, they end up with biliary obstruction, and we are unable to do endoscopy and stenting. So we end up with a discussion whether to put a drain, external drain, for the BTC or not. So how do you usually approach this kind of patient? So especially they are not going for any active treatment, so and they have biliary obstruction.
Thank you. If the patient, we have to sit and discuss with the family and with the patient the goal of care. We should also integrate with intervention radiologist to see the possibility of doing internal stent. If it's not possible, we will go for BTC, and we should respect the patient autonomy and his family. If they are refusing, we will just focus on his comfort care and be updated about the situation and the prognosis in this case.
Okay, thank you very much. Question for Dr. Mohammed Al-Garni. So I know it's just a general question. So a lot of these germline mutations are sometimes seen as somatic mutation as well. So in clinical practice, when we order these mutations, when do we consider screening for genetic inherited cancer and for the family as well?
Thank you very much, Charlie. This is a very important question because, as you know, nowadays we are doing more and more of molecular profiling, and we are expected to see some of the genes that commonly described as a germline, but it is found in the molecular profile as a somatic mutation. So if the short answer is, if the gene is known to be germline, I think you should do the germline testing as well. I think there is a trend nowadays in the large cancer center across the world that they are doing combined molecular profile and germline testing for patients. And once you confirm that the patient has germline mutation, at that point, you can start to screen the family or refer to cancer genetic clinic. But definitely, we are expecting to see more and more of somatic mutation on the molecular profile, and hence we need to do the germline testing.
Yes, please. Question from the podium.
Thank you. A question to Mohammed, like we do see a lot of young patients with the colon cancer. Which patient would refer this patient to the genetic testing? Like, is there a guideline to refer this patient to you or not? That's for your questions. Second question to Kanaan. Do you think the circulating DNA would be helping in surveillance a patient for colorectal cancer?
Thank you, Nai, for the question. I think yes, for colon cancer, yeah, there is already a guideline when to refer. Actually, due to the complexity or the details that you find in the referral guidelines, at least what we apply in our center, whenever you think that there is a significant family history of colon cancer or cluster of cancer, just we accept the referral to our clinic, then we can do our triage and our assessment. If you want to adhere to the guideline, I think the patient or the individual should fit one of the criteria, like the Amsterdam or the PSADA criteria for referral. But I encourage actually, even for our GI team, whenever they see patients, when they scope them and they found more than a usual number of polyps, to refer the patient to the clinic for proper assessment.
Thank you, Nai, for your question. A very important question indeed. But I think we are reaching an area of unknowns, and there are so many moving objects here. So ctDNA detection in surveillance, I can probably foresee a few problems. One of them, if you get ctDNA positivity and on conventional imaging, it's negative. You may have micrometastatic disease. What would you do? يعني do I call you Naif and tell you يعني let's open him up and look for يعني disease that is not shown on CT, or would I give him cytotoxic chemotherapy with its known side effects for the ctDNA positivity? I still think, I do think that we are moving into the ctDNA era. However, its applicability, I think it's still dynamic, and we're going to see more data regarding this hopefully soon.
Okay, so maybe last question to Dr. Ahmed. With regard to palliative care referral, so some studies have shown that maybe early referral to palliative care from diagnosis or even starting treatment may improve the outcomes of the patient. So is this applicable to all cancer or some subtypes of cancers? What's your thought about this? So early referral of palliative patient.
Yes, the well-known study that was published, it's about non-cell lung cancer, which increased the survival around 6 months. This study was promising, and it's open a new studies going on now. So we are waiting for the results for those study, but many of the data shows that it's improved the survival and it's improved the quality of life for those patients who are receiving chemo or immunotherapy or active therapy. Thank you.
Yes, question or comment from Dr. Muhammad.
It is just a comment about what Dr. Ahmed bin Ahmed just mentioned. I think I can see this in my practice because I see a lot of pancreatic cancer patients, and we have very easy access to Ahmed. And I think the patient come quite symptomatic in the first clinic, and sometimes you might have fair decision about whether you treat or not. And once their symptoms is better, you might change your decision. So I think it's always preferred to involve your palliative care team as early as possible, especially in patients with lung and pancreatic cancer.
Okay, so I think we reach our end of the session. Thanks everybody for joining us for this great meeting and for this great discussion. And we'll go for a break for prayer, 1 hour, and lunch. Thank you.
So we'll be back at 1 p.m. inshallah.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على أشرف الأنبياء محمد عليه أفضل الصلاة وأتم التسليم. It's my pleasure to start this session, the fifth session, last session for today. We have amazing 1.5 days yesterday as well as today. The last session will talk about mainly colorectal cancer, and we have really a nice agenda and a really interesting topic that our great speaker will present. We'll start with the first session with my colleagues, Dr. Ali Gibran. He's one of the senior consultants in King Faisal Specialty Hospital Research Center with experience more than 10 years in the GI and the GU as well. Dr. Ali, mic is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Fahad. Thank you, Dr. Fahad. Really, many thanks to the organizing committee. I will start this presentation with a case of mine. It's an unusual introduction for a review topic. Abdullah, I saw him in early 2018. He was 38-year-old. Locally advanced cancer in the transverse colon. Case was clearly unresectable by the surgeon. He has very strong family history, especially for colorectal disease. Father and 2 uncles had colon cancer. Mother died of pancreatic cancer. Brother died at the age of 20 of leukemia. Many cousins actually were diagnosed with colorectal disease. This is his CT scan. It's a transverse colon, locally advanced, T4B, invading the anterior abdominal wall, as you can see here, as well as the liver. It's invading the small bowel, and there is fistula to the small bowel. So, of course, when this case was presented in the MDT, the surgeon said, I cannot really guarantee R0 resection in this case. Please go ahead and start chemotherapy. So this is unresectable to start with. I started this patient on a triplet chemotherapy. Since this is already right-sided colon cancer, he is fit man. So I started FOLFOXIRI. And that was probably one of the first cases that I treated with a triplet chemotherapy for colorectal disease. The patient received several cycles of chemotherapy with no response whatsoever. It remained to be locally advanced T4B disease. Yes, maybe it's not progressing as per the RECIST criteria, but actually, when you look at the CT scan, you can recognize that there is probably some element of minor progression. But remember, patient is getting a triplet chemo. He's getting all strong antineoplastic medications for his disease. Of course, the surgeon decided that this is not resectable again. And to be honest, when you ask about R0 resection in this case, who is failing chemotherapy, you would argue that probably someone had to push for this patient to go to R for resection, even if there is a threatened R0 resection. The patient deteriorated. He was clinically progressing. He became emaciated and weak. He had frequent blood transfusion due to GI bleeding. The tumor was invading into the small bowel and he was requiring blood transfusion almost every week. He received hemostatic radiation dose with no benefit. He had also element of obstruction, so he underwent colonic stenting. He had severe pain, and we just thought that we are going to lose the patient. He is not responding to triplet chemotherapy and deemed unresectable by the surgeon. Remember, that was 5 years ago. And 5 years ago, we did not actually have the standard of checking all biomarkers up front for non-metastatic cases. But because of the strong family history of this patient was sent for genetic studies and genetic counseling. And we got the result that he actually has confirmed Lynch syndrome. Not in himself, but actually in many members of the family. So he has Lynch syndrome. This is MSI disease. Next step, I started this patient on nivolumab. He had remarkable improvement, unbelievable, remarkable improvement. First, he had significant clinical improvement. No more blood transfusion. He started gaining weight. He was back to his work. He was almost leading normal life. And look at the CT scan, there is significant shrinkage of the disease. But after several months of immunotherapy with such marvelous response, the surgeons still think that this is unresectable. So the next step, I actually asked for a second surgical opinion outside the hospital. I got it. The patient was found resectable. He underwent actual surgery in another hospital. And look at the pathology report. It is actually complete pathological response. So what are the lessons I learned from this case? First, I would say that don't be reluctant to ask for second surgical opinion, especially if you are not convinced. And even outside your institution. We are all in one oncology community. We all know each other. So it's really appropriate and recommended to ask your surgeon colleague for second opinion. Number two, MSI disease response to immunotherapy. That's a fact. But definitely that one was clearly established in this case. But what was the lesson to me as well, what was that MSI disease did not respond or does not usually, or actually in many cases does not respond to chemotherapy. This patient was treated with a triplet chemotherapy with no response at all. He actually was progressive. So we are talking about the chemo-resistant in early stage MSI disease. You are all aware of the Daniel Sargent data 10 years ago about the chemo-resistant and resistance in stage 2 colon cancer. And that's why the recommendation, if you have stage 2 colon cancer, MSI high, don't give fluoropyrimidine treatment. But what about the data in stage 3 colon as well as rectal cancer? I will present only 2 studies, one from rectal cancer and one from colon cancer. This is a study that was published 2021, including, it's actually a retrospective study with match control. This included 50 patients with rectal cancer, published by Memorial Sloan Kettering. 21 patients received chemotherapy. And this is matched to a control group of 63 patients with MSI stable disease. And look at the response here. 6 patients of MSI high disease progressed on chemo. That's almost 29, exactly 29%. Whereas actually all patients with MSI stable disease responded to chemo. So this is telling you that actually MSI disease is a negative predictive factor for chemo response. The second trial is from colon cancer. This is the famous Foxtrot trial, where actually more than 1,000 patients enrolled with colon cancer are randomized to either upfront surgery, which is the control arm, followed by adjuvant chemotherapy, or preoperative chemotherapy, and that's the experimental arm. And this is the result of this study. The relapse actually has decreased with the preoperative chemotherapy, as is shown very clearly here in this curve, but this is not the point. The point that they had almost 10% or more than 10% of those patients were MSI high disease. So they said, why not to look into their response to preoperative chemotherapy? Total number 106 patients, MSI high disease, did not respond very well to chemotherapy as compared with those with MSI stable disease. For those with MSI stable disease, almost 75% of them responded to chemotherapy at some extent. While in the MSI high disease, only 25% responded to chemotherapy, 75% did not respond. And there are many actually studies published already about the use of immunotherapy for MSI high localized disease. These are reported cases over the last 2 or 3 years, all reported magnificent response to immunotherapy for localized colorectal cancer. And these are the prospective published trial. There are actually many prospective published trial using immunotherapy as a neoadjuvant, but I will only focus on 2 famous trials of them. The first, as you know, is the NICHE-2 study for colon cancer. More than 100 patients were enrolled in this trial to receive only a single dose of AP and 2 doses of Nivo, followed up by surgery after 4 weeks. And look at the response. 95% of patients had pathological response, of which 67% with pathological complete response. Again, this slide just shows that patients with the Lynch responded higher or more to immunotherapy. So the conclusions of the authors or the investigators that with only 4 weeks of a treatment, unprecedented major pathological response, 95%, including 67 complete paths response. Treatment is well tolerated, no disease recurrence. The second study is from rectal disease. And again, using the dostarlimab as a neoadjuvant chemotherapy. The idea of this study is to incorporate also the non-operative management of rectal cancer. So they were looking actually at the complete clinical response. The target sample size was 30, and I can understand why it is very low, because as you know, MSI disease and rectal cancer is extremely rare. It's not definitely like colon cancer. Most of the MSI high disease actually comes from the colon, especially the right colon. The estimate of MSI high disease is about 2 to 3% only in rectal cancer. So 9 cycles of dostarlimab, and if the patient achieved complete clinical response, no radiation, no surgery. Majority of them actually locally advanced T4, N2. And again, look at the result of the first 14 patients. The first 14 patients enrolled in this study achieved complete clinical response None of them required to go for radiation. None of them required to go to surgery. So this is the conclusion by the investigator. Complete CR achieved in the first 14 patients. Grade 3 and 4 are really minimal. Chemotherapy, radiation, surgery not required by any patient. No recurrence of disease observed in this short follow-up. So the question here, is this now standard of care? Now, I checked, as far as I remember, FDA has not approved this yet, and please correct me if I am wrong, but I checked the NCCN guidelines, and I also found that NCCN guidelines did not put this as one of the options for the neoadjuvant treatment in localized disease. Now, of course, there are many arguments that can be used in this setting. That, of course, we need to have more patients enrolled into clinical trial to see that this is really effective treatment. Thanks God that no one actually asks for randomized trial, because we are now in the era of the molecular alteration-based treatment, where no need actually to do randomized trial if you know the underlying molecular biology and you know why this treatment is effective in this subgroup of patients. So you don't need actually to go for randomized trial if you have a molecular biology. But many can say that we need larger number of patients. I have this analogy that I want to use. You know, the standard treatment of anal cancer now is concurrent chemoradiation. Now, this standard has been made a standard only after publishing this very small study in 1981. 19 patients with squamous cell cancer were treated at a single arm, small phase 2 study. Those patients were treated with concurrent chemoradiation. And after adequate follow-up, the recurrence rate was extremely low. So after this, the standard of care has been changed to concurrent chemoradiation. Before 40 years, the standard of care was APR, resection. So this is a small study taken into account that we are talking about very rare disease. But again, even for MSI high rectal cancer, it is again very rare disease. So probably we should use the same argument then. Someone might say that, okay, this is very small study, but they waited for adequate follow-up to make sure that the benefit is maintained. And I agree with this argument, but this is not actually the exact case of MSI high disease. For MSI high disease, we know why immunotherapy works, and we know why chemotherapy does not work. There is no surprise that immunotherapy works very well for MSI high disease. So if you say I need to wait for longer follow-up to avoid surprises, I will tell you there is no surprises, because this is a fact now. You are talking about MSI high disease responding to immunotherapy. So why you are expecting surprises?
Dr.
And
Ali,
that's why.
Can you finish in 2 minutes?
Yeah, of course. And that's why it's called tissue agnostic treatment. You give it because it is MSI high regardless of the site of disease. Now, I'm telling you, it's really interesting, because the same thing you can ask yourself if you are faced with a patient coming to you, MSI high disease, would you give chemotherapy or would you give immunotherapy? This actually happened to me just now. Khalid, who's the direct cousin of Abdullah, you remember Abdullah from before? They are both members of Lynch syndrome family. Khalid just came to me. He is 48-year-old with locally advanced rectal cancer. The question here that I'm asking myself, am I going to start him with a new adjuvant immunotherapy or a new adjuvant chemotherapy? And also I want to ask you the same questions. Do you want to use immunotherapy for this patient or chemotherapy? Can you please show me a show of hand? Who would go for immunotherapy? Who would go for chemotherapy? Thank you so much.
Thank you, Dr. Ali, for this nice overview of this controversial or evolving topic. Next, I would like to introduce Dr. Mervet Mahrouz. She's well known to all of us. She's a consultant of medical oncology at Prince Sultan Military Medical City. And she will talk to us today about BRAF mutation colorectal cancer. What is the optimal sequence?
Good afternoon, everybody. Thank you very much, Dr. Fouad, for introducing me. And I would like to thank Dr. Fahd Al-Maqbal as well for chairing this session. And I would like first to thank and congratulate Dr. Ashwaq for her efforts and keeping this important sessions and scientific meetings, and all the organizing committee, Dr. Garnier and Dr. Kanaan as well. So we'll switch the gear a little bit to the BRAF mutation, and even this is not a high percentage as MSI. So the BRAF, it's also a very difficult disease to treat, and those patients, they're presenting with extensive disease. And so we get very lucky to have the best treatment for MSI high patient, and we are looking for the same for the BRAF specific population. So I had this interesting talk by the committee regarding what is this optimal sequence. Here is my disclosure. And before we start, we know that when we look at on the right side of the slide, you can see that colorectal now, we are looking on the genomic part. So we started with the RAS and then KRAS, MRAS, and then we do have the BRAF. And even at that time, 5 years ago or more, when we are finding that the patient was RAS mutation, was RAS wild, you cannot treat them with anti-EGFR if they are BRAF positive. And this was mandated at that time to start to even to examine the BRAF. And because this patient, they may be difficult to be treated. So putting the fact that what is not all BRAF are the same. We have most of the BRAF is BRAF wild, and it's almost 89%. And the 7% of this, it will be V600E. And this is a specific entity, and I will talk to this on a second. And there is even a subcategory, which is the atypical type, which is 4%. And it's an area in between. So the wild, it's you can treat them like a patient with the wild type, like the RAS wild patients. And for before starting with the V600, which is a difficult patient to treat, we'll speak a little bit about the V600, non-V600, which is two codons, which is 594 and 596. And you can see it's a favorable prognosis, left-sided, male more than female, low-grade, KRAS mutation, MSI negative patient, and no peritoneal deposit. And you can see here on this graph that those patients who in red, they are the V600 comparable to atypical and none. And also this was presented by the MD Anderson group. They looked at the specific group of patients about non-V600. You can see this part, which is the gray part. Here they are doing better, and those patients, they are responding to EGFR inhibitor for a patient with RAS wild. And it's not even for the BRAF, it's not only one class. So the class one is the V600, and we have two classes regarding the BRAF. And again, sorry, you can treat them like the normal population, and this is what they are. All the investigators augmented on this part. So how about the V600? We all agreed, and we all see this in our clinic, that it's a small number of patients. However, they came with aggressive type. When you look even comparable colorectal to melanoma, you can see the BRAF frequency It's almost 8% comparable to 50%. However, you can see that the death rate is almost 55% comparable to 27. So this means that the PRF positive patient in colorectal even doing worse in the melanoma. And when we look in depth on the PRF, you can see that most of these patients, they presented with peritoneal deposit, distant lymph nodes, and even here we can see that the non-PRF, they even have more regarding liver and lung. Not only this is mostly the picture we are seeing the patient as a first presentation. But most of the patients, they presented with peritoneal deposit disseminated disease, extensive, and this is what we are seeing, and we know this is a very difficult patient to treat. How about the prognosis? You know that the first line just only give you 6 months and the second line give you 2 to 3 months. This means that you are dealing with very difficult patient situation. And before going for the metastatic, even for the stage 3, we had a very good, brilliant talk with Dr. Rajabran regarding the MSI, and even for the stage 3 disease, we can see that the percentage of PRF, it's about 8%, and this patient, they are doing worse comparable with the other population. They have a shorter disease-free survival and overall survival, and also the recurrence rate is higher. And if they are with the MSI positive patient, will come to this. There is a trial, which is atomic trial. They are trying to prove the concept that MSI patients should be exposed to immune therapy, and you are waiting for this trial. So putting this in perspective, that PRF positive patient, even for a stage 3 disease, and they need to be, for a patient with a stable one, MSS, can be go for close observation. MSI, we may consider adjuvant, but we're still waiting for the data, so we may consider after. Back again to the metastatic, we know that patient with EGFR positive patient, they are not candidate to receive. Patient with the RAS wild patient with the PRF mutation, based on this meta-analysis, 4,000 patients, they not be candidate for EGFR inhibitor because of the lack of the benefit, and it was established as a policy. So how we treat this patient? We have a patient with RAS PRF wild, RAS mutant. Of course, we have the TRIB study, and you can see here that the patient with PRF mutant, if we are giving them doublet therapy, we have 10.7 months. When we are giving the triplet, it's 19 months. Even it's a small population, about 25 patients, but it was since the time Cremellini presented this study, and it was published since 2015, that those patients, because they are presented with aggressive disease, you may treat them with aggressive treatment as well. And you can see here, even on the graph, that those patients who is treated with the triplet therapy, which is deep green, you can see in between, and the least one, which is the doublet. Since this time, and I know we do have a lot of argument about this, it's a small population, it was subgroup analysis, and we don't have a study devoted for this patient, and this, we didn't have much benefit for them. However, it was put in perspective that patient with PRF positive, good performance status, extensive disease, in favor to go for the triplet. And I think we saw that Dr. Gobran, he started for his patient follifoxyria regimen based on the patient category and also the extensive disease. However, again, we need to treat the patient on biological basis, not only on the patient criterion. So is induction of follifoxyria plus bevacizumab considered? It's one of the favorable. You can see that 36% of the patient progressed rapidly through first-line FOLFOX and less likely to receive second-line chemotherapy. And so you can see that 33% versus 51%. And this is why most of the investigators in favor to go for the triplet therapy as an upfront for the PRF. And maybe this be a conversion therapy for this patient. How about the metastatectomy? 2% only of the colorectal patients who undergo liver resection based on Justin Tosi, which is published in 2017. They found that only 2% of this population, they are a PRF, and this is added to the aggressiveness of the disease. However, the patient who had a response and went for metastatectomy, they are doing better. And you can see clearly here on the graph that the patient who had surgery, they are doing better comparable. How about the PRF plus MSI? We have initial study, which is 2017 by Overman, the Checkmate 142. You can see this patient, they are doing better if you are receiving immune therapy with nivolumab. And of course, we have the landmark study, which is the Keynote 177. And we know that this study, it was about 300 patients. It was only MSI positive. It was Pembro versus the standard of care, which is Fulfox or Fulfiri, plus biologic therapy. And the primary endpoint, it was PFS and OS, and the study made the primary endpoint and overall survival as well. And when we look at the patient criteria, we can see that quarter of the patient, they were PRAF V600. And not only this, when we look at the subgroup analysis, we can see either PRAF wild or PRAF mutant patient, they are benefit from the treatment. And again, this is established the point that MSI positive patient PRAF, can be candidate even for the patient with RAS mutant. We didn't see that those patients, they benefit. However, we have a lot of argument about this because this MSI patient, we need to be exposed to immune therapy. We know this is finding, but however, if I do have patient with even with RAS mutant, I will go for immune therapy for this patient. Bottom line for the clinical trials. So how about if we are giving treatment for the PRAF? When we look at the slide, you can see that because melanoma is the highest one comparable to the colorectal as a percentage of incidence of PRAF, and also as an experience, you can see even for single agents, anti-PRAF vemurafenib give a 81 response rate comparable to 5% response rate. And this put us in a perspective why PRAF and colorectal, they didn't have this response comparable to melanoma, because it's a very complex compound. And you can see that it's not only based on the PRAF, we have also the EGFR. You need to make a duplication for inhibiting the EGFR and the PRAF, and also there is PRAF MEK as well. And so you need to block in two parts, not only in one part. And from where that's coming, the triplet therapy, the refrafenib and tremelimumab, and plus panitumumab, and you can see that the best response rate was the triplet therapy. We know that we had an FDA approval regarding the refrafenib in combination with the tremelimumab for solid tumors. However, this combination is not working actually in colorectal because of we know that there is intrinsic resistance. This is why even for this study, it was a phase 2 study and they will have a response, but those patients, didn't get better. So this, from where this came the SWAG 1406, which was presented since ESMO 18. It was the main idea for the Beacon study. And the study was only included for a patient with PRAF 600. And you can see it, patients were randomized to cetuximab irinotecan versus vemurafenib as cetuximab irinotecan. And the primary endpoint, it was PFS. And the study made the primary endpoint. And you can see that the hazard ratio, it was 0.48. However, the overall survival was negative. The Beacon study, it was done the same scenario like the SWAG, and it was the main idea, but it was done by the MD Anderson group. Scott Coptis and his group, it was about 250 centers all over the world, 15 countries, and it was the largest study ever regarding the patient with PRAF positive patient who is a second-line therapy, and the study was randomization 1-to-1 randomization, triplet therapy versus doublet versus the control arm, which is the Fulfiri plus cetuximab. And the primary endpoint, it was overall survival and the response rate as well. And you can see that the study made the primary endpoint. And since this time, it was the standard of care as a second line for patient with PRAF. So the patient who is all the patients, they were receiving upfront therapy, and even a quarter of the patients, they were receiving a second line as well. So it was between the one or two lines of therapy. And the doublet, came as the same regarding overall survival and even the PFS. And the doublet 9.3 versus 5.9. And since this time, the encorafenib cetuximab is considered the standard of care for second line for PRAF V600 patients. In the last ASCO, last year. They also looking at the ctDNA, and they look at the patient who got a good response, and they found that the patient was VF low, which means that the ctDNA, they looked at it and they stratified to low and high, and this patient with low VF, they have a better outcome regarding the response rate and also the overall survival. And just give you a hint that the patient can be responding, and you can have a biomarker for a patient with this regimen. So usually when you have a second line, which is working for the patients, how about we can go for it as an upfront? So the anchor study, it was a phase 2 study. It was presented with Rick Van Kutsen 2 years ago. And it was a phase 2 study. They looked at the patient who did a PRAF positive patient, and it was about 90 patients, stage 1, stage 2. And they give the patient this combination, grafenib, permethrin, and cetuximab, and they looked at the response rate. You can see that 47% of the population, they have a response. However, when you look at the subgroup analysis, you can see there is no meaningful difference regarding the overall survival. Maybe this patient, you need to expose them to intensive chemotherapy and then go for second line. We don't know, but we are waiting for the Breakwater study, which is a phase 3 study. They looked, they stratified the patient to 3 arms, and we have this triplet combination as an upfront. Still, we don't have the data yet, but it's about 900 patients, and we maybe this will change the policy regarding how to treat those patients. So this is a scheme how to look at the patient with PRAF. So the new adjuvant, we have the FOXTREAT-4, which is the same like FOXTREAT, but this is for the population with PRAF, and they're giving them, stratify the patient to standard of care versus cetuximab and grafenib as an upfront, and then they will go for surgery. We have the adjuvant patient as well for the Alliance study, and we have the first line and SMEC for this. One of the main elements that we have to look for it, that in the first line anchor study, when you are giving a triplet as an upfront, give you a 48% response rate. Second line give you 34%. And in the third line, you have a 22% only regarding the response rate. So this maybe change our view regarding this. Again, this is a FOXTREAT study, which is the 4-1, and it was confined. This study, it will be a huge one. They stratified every patient, the MSI patient group, and they give them immune therapy as an upfront. Patient with stable one, they stratified them to chemotherapy versus the usual standard of care, which is surgery. And for the patient with PRAF, 6 weeks of oxaliplatin fluoropyrimidine versus 6 weeks of encorafenib plus cetuximab, and then surgery and minimum 12 weeks of oxaliplatin fluoropyrimidine. Again, maybe changing our view how to treat this patient, and this is confined for a patient with potentially operable patient or irresectable patient. Alliance therapy, this is added for the adjuvant, that for the patient with PRAF, you shouldn't treat them the same. So for a patient with a stage 3 or high risk patient, they stratify the patient randomization to the usual treatment, which is Kipoxa or Folfox versus encorafenib and cetuximab for 6 months. And of course, there is a baseline ctDNA and looking for all this data. Maybe this patient, they needed to be treated different. And again, another study regarding the patient with immune therapy plus encorafenib and cetuximab, they will add pembrolizumab for this combination, and the control arm in this part is pembrolizumab, and we'll see maybe this patient, they need from the start to we have as an upfront. So this is my the summary how to treat and answering the question regarding the sequence. PRAF is a different group of patients. They are aggressive, mostly female, and of course we do have we need to stratify the patient to MSS or a stable MSI or patients with MSI high. Patient for the MSI, you need to go for the Keynote 177. For the patient with non-MSI or MSS stable, you need to go for upfront chemotherapy for the second line in encorafenib cetuximab. And here my last slide, that this group of patients, they have aggressive disease. They are presented even for the patient who is non-metastatic patient, you need to go for observation for them, or maybe consider immune therapy after we are having the atomic study. PRAF, this population, they have extensive disease, peritoneal ascites, and the overall survival for them 6 months only. And I think we need a better approach. Second line standard of care is now the established element. Thank you very much for your attention.
Thank you, Dr. Mirbat. So now at the end, we have a Q&A session after 2 more sessions. The third session, just to remind our audience, either the one who's attending or virtual, just to write in the Q&A the question if they would like to ask any question to our audience. To our speaker, sorry. So the third presentation is by Dr. Ahmed Zahrani. He will talk about HER2 and colorectal cancer, how we can manage those entities of the patient. Dr. Ahmed Zahrani is one of the medical oncologists, consultant medical oncologist in King Faisal Specialty Hospital in Riyadh, and he's specialized in GI as well as GU in the last 10 years or more. Dr. Ahmed.
Assalamu alaikum. I would, first of all, I would like to thank the organizing committee for a kind invitation for this prestigious meeting. Thank you, Mr. Chairman, for kind introduction. I have been given the task to speak about HER2 new in colorectal cancer, how to treat. So this is the outline of my talk, a little bit of introduction. I will try to answer pertinent question, which is, predictive value for HER2 new amplification to anti-EGFR therapy. I will go briefly over the clinical phase 2 data, addressing the role of anti-HER2 new, dual HER2 new inhibition, 4 category or 4 classes of drug, antibody small molecular combination, antibody-antibody combination, antibody-drug conjugate, and the novel bispecific antibody. I will finish up with treatment recommendation and then conclusion. So to start off, this is a little bit of a background. As you all know, HER2 amplification or overexpression occurs in around 4% of all patients with metastatic colorectal cancer. So if you want to enrich patient selection, then you should look for HER2 new in patient with RAS BRAF wild type, which account for around 10% of patients. It's very rarely seen in RAS or BRAF mutant, around 1%, so it's not mutually exclusive with RAS/BRAF mutant status. However, the NCCN guideline stated that no need to check for this molecular alteration in the presence of KRAS or BRAF mutation, because RAS or BRAF mutation predict lack of response to anti-HER2 therapy. Little activity to monotherapy with anti-HER2 agent has been shown in preclinical setting. So all trials that I'm going to discuss, they have used dual HER2 new inhibition. So I think one important question, whether anti-HER2 predict resistant to anti-EGFR antibody treatment. I'm going to address this question in the few coming slides. So in this particular study, they have looked into the predictive value of anti-HER2, whether it predict response to anti-EGFR. This is a retrospective study, 76 patients with HER2 amplification, 100 patients with HER2 new negative used as control. All patients received mostly first line FOLFIRI anti-EGFR. It has shown that patient with HER2 new overexpression, they have less response to anti-EGFR based therapy. Response rate as shown here, 31 versus 46, 0.9% significant p-value. And multivariate regression analysis confirm the finding that HER2-neu status predict less response to anti-EGFR. In terms of PFS, as shown in the figure here, there was a trend to worse PFS in patient with HER2-neu positive patient, 5.7 versus 7 months with non-significant p-value. There are a number of trials or retrospective studies came or reached to the same conclusion that anti-HER2 or HER2-neu status may predict less response to anti-EGFR. As you can see here in the last trial done by Swada et al. Patient, it seems patient with HER2-neu overexpression, they have similar outcome to the RAS mutant patient when they get exposed to the anti-EGFR. So collectively, it seems anti-EGFR predict less response to anti-EGFR. So that being said, the question, do I exclude my patient with HER2-neu amplification from anti-EGFR first-line therapy? The answer is no, for the following reason. The study that I went through, they are retrospective data, small number of patients, small proportion of patients treated as a first line. And I think the finding needs further validation from already conducted prospective phase 3 randomized clinical trials such as Crystal, Fire3, SWAG, etc. Moreover, a few retrospective studies have failed to show negative predictive value of HER2-neu status. So in my personal view, I wouldn't deny patient harboring HER2-neu amplification from first-line anti-EGFR therapy. So this is to address the diagnostic criteria for HER2-neu positivity. There have been two colorectal cancer specific diagnostic criteria. One of them is the International Collaborative Project Diagnostic Criteria. Both have been validated. So they have defined HER2-neu positive if you have IHC3 plus in more than 10% of the tumor, or IHC2 plus FISH positive. Heracles diagnostic criteria, they have more stringent criteria. They included, they have stated that you need more than 50% of the tumor to have IHC3 plus or FISH positive. NGS also based on the common number gain has also been validated. So now I will go to the clinical trials. All of them are single arm phase 2 study, except the Mountaineer study, which started as a single arm and then expanded to randomized phase 2. So antibody small molecule combination. This is one of the first initial efforts that evaluated the role of dual HER2-neu inhibition. Heracles study in chemorefractory patient, KRAS wild type. They have enrolled around 27 patients. Response rate was quite impressive of 30%. Keeping in mind those patients are heavily pretreated patients. Duration of response was also remarkable at 38 weeks. As you can see in the spider plot here, deep and durable response in some patients. The more recently, we have the Mountaineer Global Open Label Phase 2 trial, already been presented last ASCO GI. They included heavily pretreated patient, received at least 2 lines of therapy, HER2-neu positive patient, RAS wild type, measurable disease. So they have started with 45 patients treated with combination of tucatinib and trastuzumab. Then they went into expansion cohort, and they have run with randomization to same combination tucatinib trastuzumab in cohort B against cohort C, tucatinib as single agent. Primary endpoint was response rate in cohort A and B. Secondary endpoint was response rate in cohort C. So this is just to illustrate the point that those patients are heavily pretreated patients. All patients received fluoropirimidine, oxaliplatin, irinotecan. Some of them received anti-VEGF and anti-EGFR. So looking at the response rate, it was quite a remarkable response rate of 38.8. Median duration of response was 12.4 months. So there's promising activity of this combination. This is the waterfall plot. You see some patients, they achieve deep response, and nearly 2/3 of patients have some sort of tumor shrinkage. This is really quite intriguing that it seems only patient with left side tumor, similar to data from anti-EGFR, derive much benefit from anti-HER2/neu treatment. Left-sided colon, they have a response rate of 42 versus 15% in right-sided colon. So the quite also remarkable BFS of 8.2 and overall survival of 20.4 months. And just keep in mind, those are heavily pretreated patients. For tucatinib monotherapy, there was not much of response rate of 3.3, which kind of, in keeping with old finding that anti-HER2 monotherapy does not have much activity. This is quite intriguing finding from, this is, translational work from Heracles study. As you can see, they have looked at the correlation of circulating tumor DNA, HER2 amplification in circulating tumor DNA, and correlated with response rate and BFS. As you can see, there was a higher response rate and better BFS in those patients with high plasma copy number. And this may be used as an alternative to tissue-based HER2 amplification. What about antibody combination? We have the My Pathway study. Again, this is one of the initial initiatives in this field. As you can see, the patient with RAS wild type received combination of pertuzumab and trastuzumab. Very promising results, response rate of 32%, and the median overall survival of around 12 months. Two findings that I would like to withdraw your attention in this particular study. First of all, they have included 13 patients with RAS mutant. Only one patient has responded. So subsequent trials, they have excluded patient with RAS mutant from enrollment. Second point is that none of the 8 patients with HER2 amplification without overexpression responded to dual anti-HER2 therapy. So this is another study that evaluated monoclonal antibody combination, a very small study. However, they have what's peculiar about this study, they have included patient with HER2 amplification in the tissue or circulating DNA analysis, and they have shown similar sort of response rate, whether you use circulating DNA or tissue-based HER2 amplification. So this also been shown in another kind of tumor that, circulating DNA may replace the tissue-based diagnosis, especially if you don't have enough tissue to perform HER2/neu amplification. What about antibody drug conjugate? We have the Destiny CRC01 evaluating the role of trastuzumab deruxtecan. This has gained the momentum, and it has shown quite remarkable activity across many cancer types, including breast and gastric cancer. In this study, they have enrolled patients with HER2/neu expressing patient, chemorefractory patient, RAS BRAF wild type. Interesting that they have included also patients with prior HER2/neu treatment in around 1/3 of patients. 3 cohorts of patients, classic HER2/neu positive, IHC3 or IHC2 plus FISH. They have included patients with intermediate and low HER2/neu because of in the breast cancer field, they have shown those patients with low HER2/neu, they do benefit from trastuzumab deruxtecan. Primary endpoint response rate. Response rate was again quite remarkable in patient with classic HER2/neu positive, 45.3 response rate. What's, in my opinion, quite important in this study, those patients with intermediate HER2/neu and HER2/neu low, they have no response whatsoever, which is quite different from what we have seen in the breast cancer. In the subgroup analysis, the HER2/neu status seems to predict response to trastuzumab. Only patient with IHC3, they do derive benefit. IHC2 plus positive FISH, they don't derive much benefit. Prior treatment does not preclude response to trastuzumab deruxtecan. Similar kind of response, whether you have been exposed to trastuzumab or not. And this also showed a remarkable response rate in the waterfall plot. Again, there is drastic difference in terms of response in classic HER2 neo positive patient. You see the median overall survival, for instance, was 15.5 in cohort A classic HER2 neo positive versus 7.3 or 7.7 in patient with intermediate or low HER2 neo. A word of caution, this medication has been associated with 3.5% fatal toxicity related to interstitial lung disease. Now we do have established guideline to monitor and to treat those patients early on in the course, and this has shown to reduce the mortality. Unfortunately, Heracles B was negative, evaluating another antibody drug conjugate, TDM1 plus pertuzumab, failed to meet its primary endpoint. Response rate was only seen in 10%, so this is considered negative study. The last, class of medication is a novel asymmetric bispecific antibody. This is, essentially a compound that contain trastuzumab binding domain in one side or one arm, and pertuzumab binding domain in another arm. So there are, two molecules in a single antibody, similar to what we have seen or what has been evaluated in my pathway study. However, intuitively, this might not have an advantage or difference from what we have been used in my pathway study. However, preclinical data have shown if you have two agents in single molecule, you have more degree of receptor down regulation and internalization, and therefore you get more deep and HER2 neo signaling pathway inhibition. This has been evaluated in a single study, 13 patient colon cancer cohort patient comprising 13 patient, also remarkable response of 46.2. So this deserves, further evaluation in metastatic colon cancer. This is just to summarize the single arm phase 2 studies that have shown consistent activities. So the question now, how does anti-HER2 neo data compare to standard third line and beyond? If you take if you look at 1 year survival rate in tucatinib trastuzumab study, again, you get very encouraging 1 year response rate of around 72. Similar finding also in trastuzumab deruxtecan. However, if you look at the regorafenib standard third line therapy in unselected patient, 1 year survival is around 30%. So it gives you a hint that targeting anti-HER2 has substantial activity. However, this has to be interpreted with caution. This is different trial design, different patient population, but it suggests that targeting HER2 neo might improve patient outcome. So anti-HER2 neo therapy, what is the next step moving forward, is to be evaluated in the first line setting because of the strong signal of activity that have been shown in the subsequent line of therapy. HER2 neo may predict lack of response to anti-EGFR in the first line setting, and standard, the dual HER2 neo inhibition or anti-HER2 based therapy has been standard first line in advanced gastric and breast cancer. So by searching the clinicaltrial.gov, I found only one first line study, Mountaineer 3 trial, which is again evaluating the role of combination of tucatinib plus trastuzumab plus FOLFOX chemotherapy against standard therapy FOLFOX, Avastin, or cetuximab in first line setting, RAS wild type, a measurable disease. They have included patient with treated stable central nervous system disease because from breast cancer experience, tucatinib has substantial activity in the brain. So what does NCCN guideline recommend or state? They have included trastuzumab with pertuzumab or labatinib, or trastuzumab deruxtecan as a third line or beyond. Also, they have included similar combination in the second line setting after failure of first line chemotherapy. So I think the pertinent question, in my opinion, for anti-HER2 therapy, first question would be, what would be the best treatment regimen and sequence? I went over the trials. They are quite limited, low level of quality of evidence. It's limited to phase 2 studies, except Mountaineer, which was also small randomized phase study. So there are certain factors that one might use to select best treatment option. Of course, access to medication, availability of medications, toxicity profile. My preference would be to use my pathway protocol, trastuzumab, pertuzumab, because from also breast cancer experience has shown favorable toxicity profile. Cost also would be an issue. Patient characteristics, patient with CNS metastasis, I might opt to go for trastuzumab ticotinib. So the second question would be, in which line? I think we should stick to the evidence and use this kind of treatment in the third line and beyond. NCCN guideline, they suggested to use this kind of regimen maybe in the second line. And in that case, I might do circulating DNA just to confirm RAS wild status, because RAS mutant seems to predict lack of response to anti-HER2/neu. So to conclude, HER2/neu status should not preclude patient to receive first-line anti-EGFR-based therapy. Evidence for activity is limited to single-arm phase 2 trial comprising small number of patients. Nonetheless, data is consistent and showing very promising activity in RAS-BRAF wild patient in chemorefractory setting. This has been, some of these regimen have already been adopted by NCCN guideline. It can be administered as a second line. However, I would do circulating DNA just to confirm RAS wild status. No FDA approval yet. However, trastuzumab tucatinib, as per the Mountaineer study, has granted accelerated approval. Mountaineer 3 trial is the only ongoing phase 3 trial evaluating the role of anti-HER2/neu as a first line in this space. I think we need better refinement of HER2/neu diagnostic criteria. As I have shown in the my pathway study, amplification alone is not predictive for response. And in the Destiny study, only IHC3 plus derive much benefit. With that, I conclude. Thank you very much.
Thank you, Dr. Ahmed. Very nice. So we will leave the questions till the end. We will move to the next session. It's a debate session, actually. It's about oligometastatic colorectal cancer with liver metastasis. We have my pleasure to introduce Dr. Naif Zahrani, who's going to be with the surgical option. Dr. Naif Zahrani is one of the team at National Guard, and he's a surgical oncologist, and he has special interest in peritoneectomy, HIPEC, and liver resection. Dr. Naif.
Okay. Thank you. I would like to thank the organizing committee for inviting me to talk about the role of surgery in liver metastasis as a debate. And I didn't have any financial disclosure or conflict of interest. When I thought about it, I said, what's the first slide? And I said, this is the best slide to start my debate. If you cannot convince them, confuse them. So the fact about colorectal liver metastasis, like around 30% of the patient with colorectal, they present with liver metastasis, and around almost 30% of a patient who have liver metastasis, they present also with extra-abdominal disease. Having said that, if you have extra-abdominal disease, it's not considered to be contraindication to do liver resection. 25% of the patient with liver metastasis, that they are candidate for resection. Liver resection by itself, it's considered to be the gold standard for curative intent, with a 5-year survival, 50 to 60%. The goal of surgery is to resect the liver metastasis with adequate microscopic negative margin with sufficient future liver remnant. The history of liver resection started, this is the first paper out in 1990. When they put the criteria, the liver resection should be the size less than 5 centimeter. It has to be 1 centimeter margin, and it has to be like less than three liver lesions. And as a result of that, 90% of the patient with liver metastasis will not be candidate for resection. And after resection, the 5-year survival is very poor. However, because of the improvement in systemic chemotherapy and the imaging technology and the technique of the surgery, this criteria has expanded more. So the most important things when we do liver resection is to have future remnant of the liver would be enough, and remnant liver to body weight ratio, which has to be more than 0.5. So when a patient came with primary colon cancer and liver metastasis, this is considered to be synchronous liver metastasis. Around 20 to 30% they presented synchronously. And usually synchronous liver metastasis usually associated with poor prognosis than metachronous. So what are the options if you have a patient with primary colorectal cancer and liver metastasis, resectable liver metastasis? There are 3 different approaches. We could do stage procedure, which is traditional. We do the colorectal cancer resection first, then chemotherapy, then resection of the liver after that. Or we could do liver first, then after that, the colon cancer after that. Or we could do simultaneous resection. And that's dependent on the patient. So the patient has primary bleeding or obstructed or perforated. Usually we deal with the primary cancer first, then the liver after that. And the synchronous liver resection with primary resection has similar mortality among all these options, with 2% mortality rate, around 4 to 50% complication rate. The advantage of doing the synchronous liver resection with the primary resection at the same time has shorter hospital stay, and of course it's more cost effective for hospital with similar oncological outcome. So this is the database registry of patients with liver metastasis and synchronous liver metastasis and primary colorectal cancer. The whole population 5-year survival around 50%. And the survival, whether we start with the liver first or the primary colon first or simultaneous, are similar among all these groups. However, if the patient has multiple bilobar resectable liver metastasis with primary in situ, when we start with the liver first, the survival is slightly better than doing the simultaneous resection. So it has, among all these type of options, they have similar oncological outcome with the survival, with disease-free survival. Liver tumor burden and performance status has major influence in the decision which approach we go. Simultaneous group has slightly more complication, and that might affect the long-term survival theoretically. But like in generally, if we do minor liver resection less than 3 segments, usually we do it in the same time with the primary colon resection. Major liver resection or major hepatectomy should be done, shouldn't be done simultaneously. So this is the approach. We have solitary liver, colorectal liver metastasis. Usually we do it together if the patient has good performance status. If there is multiple bilobar resectable colorectal liver metastasis, we do it in a stage procedure. So how about a patient who has multiple bilobar liver disease, which are not resectable like this patient? These patient has different approach. So we could do 2-stage procedure, like we start with the small liver resection, then we do portal vein embolization to make the contralateral loop hypertrophied and do major resection in a stage procedure. Or we could do ALPS procedure, which is associated liver partition and portal vein ligation, which is has some issues and some concern, safety concern. Or we could do combination liver resection and ablation in the same time. So with 2-stage procedure, when you have unresectable bilobar liver disease, we resect the small liver resection first. Then after that, we send the patient to interventional radiologist to do portal vein embolization to make the other loop hypertrophied. In a 3 to 6 weeks time, come back to do major hepatectomy. The problem with this stage, around 33 patients who had minor liver resection, they will not continue to have to go for the 2nd stage because of the progression of the disease. So like this patient on the left-hand side, the liver resection initially the left side, Then after that, portal vein embolization to make it bigger, and come back after 6 weeks to do a major hepatectomy in the right side. ALPS procedure mainly in Europe. They do ALPS procedure. Take the for those patients who has unresectable bilobar disease. They do ligation of the portal vein and splitting the liver. And in the same time, the same admission after a week, they come back to take the liver out. But it has learning curve, it has high complication, high mortality rate, and mainly it's done in Europe. And combined liver resection and ablation is very attractive nowadays, which has similar similar oncological outcome to the other type of surgeries. So what are the prognostic factors for patient underwent liver resection? Age, the older age group usually do worse than younger age group. If you have a patient with a lymph node around the portohepatic or extrahepatic lymph node metastasis, usually the survival will be worse than the patient who has no lymph node during the liver resection. Of course, number of liver resection has prognostic factor. Single liver lesion, usually talking about 5-year survival around 60%. When you have more than one lesion, that would be dropped to 40%, 5-year survival after resection. If you have a tumor that's producing CAA, usually that will have the 5-year survival after liver resection, 40% comparing to 60% with non-tumor marker production liver metastasis. KRAS, BRAS mutation has worse prognosis than in mutated patient than wild type. Margin. So we talked a lot about the margin lately, and we don't need to have 1 centimeter margin. Negative microscopic margin would be enough to have to be completely resected and with good outcome. How about the patient has liver metastasis and extra abdominal disease? So this is from French study, who has a patient who has liver metastasis in addition to extra hepatic disease like peritoneal disease or lung metastasis. And when these all resected completely, radically, the 5-year survival around 29%. So extra hepatic metastasis, when it's controlled, is not considered contraindication to do liver resection. The role of chemotherapy in liver metastasis, I'm sure you guys are aware about this. RCT, when they have patient who has, an 80 patient who has perioperative chemotherapy and liver surgery, liver resection, versus 180 patient who has surgery alone, with very well-balanced characteristic. The outcome, the long-term survival are similar whether you give chemotherapy perioperatively or not, but the disease-free survival is better when you give chemotherapy. Another role of adjuvant chemotherapy post-liver resection. This is from the Japanese study of randomized controlled trial. Almost 150 patient has surgery alone versus 150 patient who has surgery with adjuvant chemotherapy. And not surprisingly, the survival are similar, but the disease-free survival are better when you go adjuvant chemotherapy. So how about recurrence liver metastasis post-hepatectomy? This is a database from the French, around 2,300 patients who has recurrent liver metastasis. The recurrence rate after hepatectomy around 50%, and the factor affecting the recurrence is when you have a patient with lymph node positive, more than 3 liver lesions, and when they have tumor more than 4 centimeters in the liver. And most of the recurrence in the hepatic, in the liver, but it could be happened also in the lung and on peritoneum. Most of the recurrence within the first 18 months post-liver resection. And the 5-year survival with no recurrence, 63% comparing to 44%. And is there a role for resection? Yes, when you have a repeat hepatectomy, the 5-year survival after repeat hepatectomy, 56% comparing to single initial hepatectomy, 67% 5-year survival. So local regional approach. If you have a patient that's not candidate for liver resection, there is a different way of local regional approach like radiofrequency ablation. And it has to be less than, the tumor less than 3 centimeters, the number usually less than 6 in number. It has to be away from the bile duct, and it has to be the lesion away from the blood vessel to avoid the heat sinks. So the ablation doesn't work when you have a tumor next to the blood vessels. Cryotherapy has comparable outcome to radiofrequency ablation. HAC, hepatic artery chemotherapy, very interesting topic with the 50% response rate and 20% conversion of non-resectable tumor into resectable tumor. NSIRT, which is there, has comparable outcome to chemotherapy. So when we talk about stereotactic radiotherapy, I'm sure Saif will talk about. My argument here is we're talking about non-curable outcome. With all of the study here shows about 2 years control around 80%. And we have a tumor less than 4 centimeters, the median survival 27. If you do stereotactic radiotherapy, when you have a tumor more than 4 centimeters, that will be dropped to 15-month median survival. So size doesn't matter for those patients who receive stereotactic therapy. So does size matter in stereotactic? I would say yes, while in liver resection, probably not big difference. Location of the tumor in the liver, it has some issues when you do stereotactic, especially when it's next to the stomach, bowel, or rib. And when we do, I believe 20%, they have, when I operated a patient post stereotactic therapy, and it was like really bad because of the portal hypertension. So at least 20% of those patients will have portal hypertension and will make the surgery after radiotherapy harder. And we're talking about non-curative treatment and stereotactic therapy. I think this is my debate. I hope I won the debate, safe. And before I finish my talk, this is the first Middle East Peritoneal Surface Malignancy Conference. It's going to be in Jeddah from 4 to 6 of February, where we talked about all the peritoneal disease from different GI and gynae origin. And we will have almost going to be 21 international speakers. Thank you.
Thank you, Dr. Naif, for the nice overview. We will have to find out if you are the winner or not after the talk of Dr. Saif. So our friend, Dr. Saif, he's a consultant in radiation oncology at National Guard, and he's the head of the radiosurgery, brain and body radiosurgery unit. And he's going to talk to us about, try to convince us that radiosurgery is better than surgery for oligometastatic liver disease from colorectal origin.
Assalamu alaikum. Thank you, Dr. Ashwaq, for the invitation. Thank you, Dr. Fouad, for the introduction. So, my name is Dr. Thaqfi. I'm a radiation oncologist in the National Guard Hospital. So, I will talk, when we talk about, the role of radiotherapy in the liver disease is based on the oligometastasis group of patients. And as you know, defined in 1995. And the definition is wide from 3 to 5 metastases. as intermediate stage between poly incurable disease to potentially curable disease. And in the last maybe 5-10 years, we have like more definition like oligorecurrence, oligoprogressions, and that's just describe the heterogeneity of those groups. There is no clear oligometastasis definition or entity include all the patients. So we have a lot of variability there, and that's will adjust the outcome of those patients. The goal always in treating those patients is either to cure them, and that's the best goal to achieve, or increase their survival, or improve their quality of life. So, and that's very important factor as well, as we know those group is heterogeneous. You're not going to cure all of them. So we need to keep in our mind the quality of life for these patients. Radiation-induced liver disease is one of the very serious side effects of radiotherapy, veno-occlusive disease of the liver. That's what prevents us from giving treatment to the liver like many years ago. It can lead to liver failure at the end and also can lead to death. Then, I mean, with the advances of technology, we've been able to deliver very high precise radiotherapy called SABR or SPRT. So it is 1 to 5 fractions, ablative dose, very sophisticated planning, very rapid dose follow-up. So it is just radiation to the tumor without involving the other structures. And the basic of this is simple. This is like a biological equations. If I give like 60 gray in 30 fractions, biologically it's equal to 72. If I give the same dose just in 3 fractions, it is more than double the biological effectiveness of this dose. And that's what the basic of SPRT. Technique-wise, the issue always with us in the liver is its movable structure. So we need to control that before we give the radiotherapy. The way to do it nowadays, we have what we call the 4D CT. So we do a scan, encompass the liver in all the respiratory cycle, and inspiration, expirations in between. We gather all the information that give us an idea about where is the location of this tumor during the whole breathing cycle. And then we integrated that. That's mean we give the ablation margin will be bigger to encompass the whole movement of this tumor. We can also gate or breath hold, like we specifically treat in a specific breathing area, like end of inspirations or expiration. That's difficult for the liver patients since they are old and fragile and all of that. So it is not done usually in the liver. Abdominal compression, so it is like a special procedure. We put like a belt on the abdomen, so that's decrease the breathing amplitude, so and that's decrease the motion. The new things which is like we're doing is the tracking. This is the most advanced technology. And that's what we do in our center, CyberKnife. CyberKnife, this is like very sophisticated machine. So it track the motion, track the tumor in real time. That's through X-ray following a marker we inserted inside the tumor. And also this infrared camera just measure the breathing of the patient externally. All this information gathered to the system, and the system then develop a model to the breathing. And that's what, as you see in this clip, so the machine actually move with the tumor as the tumor move with the breathing. And that's through as the patient wearing the vest and also the X-ray being taken. This is the vest, as you see the black one here. And all this information gathered to create a model for the breathing. And that's information, it's being fed to the machine every 3 to 5 seconds. So if there is any change, like the patient cough or anything, everything will stop, create a new models, and then go back to treat the patient. The new things on the tracking is a machine with MRI. So a machine has MRI inside it. So it takes MRI before the treatment and during the treatment, and if there is any adjustment on the change of the tumor or movement, then you can calculate the dose and give the dose exactly to the area you want. So let's start with the case, just to give you an idea. This is a 45-year-old gentleman with the T3-in-1 disease, rectal cancer. So presented in the tumor board The decision was neoadjuvant chemotherapy, chemorad, 50.4 given, surgery, ABR, T2 N0. Then he received adjuvant chemotherapy, Gelox 4 cycles, and that's finished in November 2019. Then in January 2020, he developed liver metastasis, so more than 5. So he's outside the oligometastasis window. So he received Xolair and a fasting 18 cycle, then good response, chemotherapy holiday, few months, another scan, progression in the liver, then chemotherapy, again, different protocol, irinotecan, cetuximab, and then he left with this disease. So he has 3 lesions in segment 8 and segment 6 to 5 here. So we have these 3 lesions. So that's what we call the new term is induced oligometastasis. So this patient become 3, like have 3 lesions. So he was referred to radiotherapy. So the first step, we put the fiducials. After the fiducial, we obtain the scan. So for planning, we can identify the tumor with multiple like images, and we can fuse all these images in MRI. As you see here in the yellow, and then we put the red, which is the ablation margin. And as Dr. Naif mentioned about the toxicity in the stomach and all of that, that's all can be anticipated pre-radiation. So we do draw all the organ to make sure that there is no exceeding dose to those organs. So everything is known in retrospect before we give the radiotherapy. After that, this is the planning. As you see here, this is the red is the tumor, the orange is the ablative dose. The pink one here is the 50 isodose line. This table here showed you that all the doses, we calculate all the doses to all the organ, ribs, spinal cord, the stomach, esophagus, heart, everything. And that's just show you the dose. Here, show you the beams. So with the saber knife, we send like more than 200 beams, like pinpoint beams, to be at the end to give you this dose to the tumor. So after more than a year, like year maybe and 3 months, in December 2022, this is the MRI. So all the region disappear, but we have a new region at segment 8. And this patient now is just been referred for another saber treatment, which he gonna have in the next few weeks. So all the treatment, all the lesion being treated disappear, and we have new lesions. And that's sometimes what happened with those patients. Those not the best patient we see. So they already started with a lot of disease to start with. If we look at the evidence, with all respect to Dr. Naif and to the surgical community, there is no evidence for the surgery. All the surgery is historical evidence. When we say curable disease with surgery, there is no evidence. The evidence in medicine come from either randomized trials or like at least like phase 2, phase 3. All the surgical data is retrospective and historical data. And I'm just asking, I mean, at what time in medicine we start to treat patient based on history? So the strongest evidence in the oligometastasis actually coming from the RFA. So the randomized trial, which randomized patient in colorectal cancer between either chemotherapy alone or intervene with the disease, the local disease, is coming from the RFA. This is the trial which showed progression-free survival benefit, no overall survival benefit, and actually the recurrence rate at this trial was around 16%. The second best in the evidence is coming from the stereotactic. This is not the colorectal cancer. This is all oligometastatic disease. The Saber Comet trial included patient with breast, colorectal, like third of the patient, and multiple sites, lung, liver, adrenal. And that's between either chemotherapy, the standard of care, or chemotherapy with ablative radiotherapy to all the site of metastasis, up to 5 metastases. And in this trial, you can see clearly there is survival benefit, overall survival, and progression-free survival. So this is for like the level one, like the level 1 evidence available for oligometastasis disease. So if we look at, the data for radiotherapy, this is the table showing, most of the trial, phase 1 and phase 2 trials. As you see here, the control rate, the two-year local control rate is above, like from 90 to 100%. So I think Dr. Naif table was either Photoshop or something, I don't know. Because as you see, the number here is like in the 100 to the 90. And I will tell you what the heterogeneity here because of the dose. So we are in the learning curve of the SABR. So with the dose, different doses will have different outcome. Also, the expertise of the radiation oncologists play an important role. So if you see here, and dose is mixed, it's not colorectal cancer, it's mixed bag of patient, and you see local control is high, survival 2 years, overall survival is also good as well. And this is not the bag of patients come to the surgery, the best of the best. The patient coming in the wheelchair and they have 10 metastases and nobody want to operate on them. So the bad patient that we receive, the bad patient, and this is the result. And this is another table just from like another systematic review showing also like this is phase 1 and phase 2 trial. This is not retrospective trial. And it shows you like the variety of local control, 100 to the 90 to the 85%. The lowest you see here is around 70%. And again, it depends on the dose. See the 70% here in single fraction. This is we don't use anymore at all. And we don't have any grade 5 or grade 4 toxicity, all grade 3 or grade 2. So this is very good toxicity profile, and the patient can be easily treated systemic therapy after the radiotherapy. If we look at, in particular, colorectal cancer, this is the prospective trial of colorectal cancer. The patient is usually not only liver and lung. So in those trials, you can see also the control rate at 2 years or 3 years, approaching the 90%, 92%. And in some trials, it depends also in the dose, it can be less than that. But look at the size of the tumor. We don't have like the small tumor solitary, it is multiple tumors, and it can approach 6 centimeters, and this will affect the result definitely. A lot of questions usually come also for like comparing the RFA with SPRT. SPRT is the last player coming to the game of the liver, because always been the surgery as historical and then RFA. So if we compare, this is a comparison meta-analysis between the RFA and the SPRT liver metastasis. And if you look at this is including primary liver disease and also metastasis. But if we look at the metastasis alone, you're going to see here for the recurrence, it is between 60% control in the RFA in comparison to the SPRT 83% in this trial. Also, if we look at all the patients on the liver, the control rate for the SPRT is better, 83% in comparison to 71.8% for the RFA. Quality of life, we have quality of life, also prospective trial in quality of life. And in this trial, we don't see any change in the quality of life after SPRT. You're going to see some drops in the first 3 months, and especially nausea, fatigue, and this is dropped. Usually the patient come back to the normal after 6 months from the SPRT. Let's see another case. So this is 49 years old who had a big splenic flexures tumors, so treated with surgery in 2016, T3 and 0 RAS mutated, thought by medical oncology low risk, no need for adjuvant chemotherapy. So in October 2016, so this is within 6 months, we can call it synchronous metastasis. He developed multiple metastases, 3 lesions in segment 8, segment 6, as you see. One here, and this is the one in segment 8. So he received chemotherapy Xelox for 6 cycles. And then this is after the chemotherapy, before the treatment. As you see, this is the lesion in segment 8, and then we move down here to the segment 2 lesion in segment 6. And this is the last one. So referred for radiotherapy. So fiducials insert, like we insert the fiducials. So as you see the radio opaque one here, and this is through the either ultrasound guided or CT guided. Here also we contour just identify the area of the tumor with the ablation zone, then all the organ at risk also decided. And this is the plan, as you see, for all the lesions. And so he was treated, I think, in 2000, let me just check. So 2016. And now we are in July 2022, and this is his MRI. He has no disease at all. This is more than 5 years post the treatment. No disease in the lung, no disease in the liver. This is the MRI of the liver. I brought all the images. Take me a lot of time, but just to convince you that it's not a snapshot of the image. That's all the MRI. So let's talk about the things affecting the radiotherapy. So from our data, like we look at like big data set of patient, the patient receiving chemotherapy affecting the results. So the heavily treated patient will do poorly after treatment. And that's all our patients. And also the histology, if we look at the histology here, pancreatic cancer, colorectal cancer is more radioresistant. They do badly with radiotherapy, that they need more dose. They are worse than breast and lung, for example. Here another also big data big data set of patients, more than 200 patients treated with radiotherapy. This is specific in colorectal cancer, but multiple sites, liver, lung, lymph nodes. And that showed that the liver had the local recurrence. So the liver do the much like the worst things. The best thing will be for the lung and the lymph node. Here, this is the dose. And this is important that we need to increase the dose. Higher dose is higher local control. So here, this is the last line with the low recurrence is with the fourth quartile, which is like a specific dose. They assign it to this diagram. So this is the highest dose, you get better control. And also the volume matter, as Dr. Naif mentioned. So the largest the tumors not only affect the local control, it's the survival. So here, less than like more than 17.5 cc, which usually the 4 and above centimeter lesion. So that will have worse overall survival. So a point about like the surgical like data. So this is one of the meta-analysis for after hepatectomy for colorectal liver metastasis. Good result, like 1 year and 3 and 5 years overall survival is very good. But as Dr. Naif mentioned, there is a high risk of recurrence to the liver. It's the range from 30% to 70% in those trials. And if we look at the disease-free survival at 1 year, it is 62. That means 42% of those patients will have disease recurrence after the treatment. So as we mentioned before, the oligometastasis is a big bag of patients. It is very variable patients. There is no specific identity, like entity of those patients will do best. So I think we need to identify those patients better, because to me, to go for a surgery with morbidity and mortality and 40% chance to have disease recurrence somewhere else, and then he will gain nothing from going through these procedures, that will not add to his, disease-free survival. So we'll go back to the chemo, but will be with more morbidity, and he lost quality of life, which one of the goals for treating those patients with oligometastasis. Let's look at this last case. So this is a 64 years old gentleman, stage 3 colon CA, diagnosed in 2013. So he had, as you see, it was a sigmoid cancer here. So he had surgery, then adjuvant Zelox for 6 cycles. In 2015, he had 3 liver metastases, segment 8, and 2 in segment 6, those, the small one, this one here and this one here. So he was treated with surgery right away when he was identified with this tumors. So he had partial hepatectomy. I think before Dr. Mohammed Zahrani was the one who did the surgery. This patient was obese patient. He wasn't the best for, any treatment, but the surgery was done for him. For that, Dr. Ashwag, I think she was the one treating this patient, wasn't performance good to give him like more advanced chemo. So he has Zloda for 8 cycles. And after 2 years, he develops this lesion at segment 8 and other lesions. And at that time, it was assessed, and because of his comorbidity performance at this stage, he couldn't offer another surgery. So again, when they stuck with those patients, they refer to radiotherapy. So we can't do anything. So now refer to me. So we get the fiducials, as you see here. And this is the lesion being identified and all the organ at rest, including the liver, esophagus, stomach. And this is the radiation dose curves. And he's like, this is 2017, and now he's 2022, and that's his liver free of tumor. He has no lung lesions, nothing. So he's cured of his disease more than 5 years now. This is like from the rare instance, we are friends with the surgeon. So we combine the two things, radiation and surgery. So surgery and SBRT is not in colorectal cancer. It is not a fair comparison. So the best patient goes to surgery. If you give me like the patient with solitary or best patient, they didn't receive heavy chemotherapy, so they don't have radioresistant disease, radioresistant tumor, and then you compare, then that's a fair comparison. So that's a fair comparison to compare, but we get like the patient with multiple metastases, like very old, performance 2 or maybe worse, and then we need to compare the two treatment. It's very difficult. However, still the evidence is to go with the surgery, but this is based on historical data. There is no comparison between the other treatment options. So we have high evidence, higher than any other, like the evidence in SBRT, in oligometastasis disease, liver and lung and other lesion is the highest upon all the other treatments, high local efficacy. We can treat multiple sites like lung and liver, adrenal, bone at the same time. So also no interference with systemic therapy. The patient can be treated with chemotherapy 2nd week after SBRT. Toxicity profile very low. We don't see grade 4 or 5. Actually, we collect our data. I treated more than like 100 patients in liver. We treated a lot lung. We don't have any grade 4 or grade 5 toxicity. It's very low in our data as well. It is less invasive. So the only invasive things is the fiducials. And this is only one technique of SBRT. There is half of the technique of SBRT is there is no fiducial. So it is non-invasive completely. And also it has short recovery time for the patient quality of life as well. And by that, I conclude.
Doctor. Thank you, Dr. Saif, for this debate. If you can kindly, our speaker, come to the stage, Dr. Mahrouz, Dr. Zahrani, Dr. Gibran, Dr. Naif. So we can start our Q&A session. So I will start with the last hot topic. All of the 4 topic was really great. And thank you, Dr. Ashwag, Dr. Al-Ghani, for choosing those topics that usually in the challenging to our practice. So I will start with the end, with the last, session. Although I'm usually with radiation, this is I'm with the radiation team, but this time I will be the opposite side. So with respect to Dr. Naif, regarding the, Dr. Saif, regarding the data, you mentioned that sometimes you do not have that enough data. You can just count on retrospective studies, and based on that, like what Dr. Gibran mentioned, Dr. Zahrani, some of the standard of care now is based on phase 2 single arm, or even sometimes phase 1 single arm. My question to you is regarding not this entity, regarding the combo IURT with the surgery. What do you think about that?
So you mean interoperative?
Yep.
Intraoperative radiotherapy is just in specific cases. It's not indicated in the liver. It is more with like recurrent disease, especially on the pelvis, like rectal. But the data on it is weak, like is not the strongest data, but it is helping in the patient for re-irradiation. So if the patient received radiation before and we want to treat him again, the intraoperative radiotherapy is better. So it saves the patient from the toxicity, and that can combine with the surgery easily, especially in the sarcoma. And as I mentioned on the patient recurrent rectal cancer. But in the liver, the combination usually either we do it in our center sometimes if it is like some lesions difficult to be resected and the other can be. So it can be two-staged, it can be resected, the lesion, and then we treat the other lesion. That's the combination I see valid for the colorectal patients.
Fair enough. At the same point, Dr. Saif, regarding the oligomastatic, however, it's involving two organs, liver and lung, for example, which is the most common. So you still think that the radiation, they have superiority hand here compared to the surgery and radiation, or you think no, that the surgery is better at this setting?
Regarding the lung, showed equal in the metastatic and in the new also the, as you know, in the primary lung cancer, the radiation is equivalent to the surgical. The liver, we don't have this data. So for the lung, I would say comfortably that we have the same result. And regarding, I mean, the point you mentioned before, yes, sometimes we base on the history, but I can, tell you the story of the lung cancer. So the lung cancer being for decades is a surgical entity because it's just historical data. And when we stepped in and we get the trials, multiple trials, now you can see it in the guideline. It is the first choice for inoperable, and now it is comparable to the operable stage 1 lung cancer. So when you get the same patient and then you compare the both modality, this is the fair comparison. But if you base just in what's been done like 30 or 40 or 50 years ago, this is not fair for the patient or for me to decide for those patients, because things improve in the medicine, and the only way to say this better than that is to compare it on a trial. You cannot base it just on historical data and you say that's what we have. So, but still, I will consider, most of the patient, that's the surgery for the liver metastasis is the standard of care, but they should listen for the SPRT from the radiation oncologist, and the patient can make his mind. And that's what I tell my patients. Still the standard of care is the surgery. I can provide you with this, but you have like 40% chance that the disease will come back again with diffuse other metastasis, and then you've been like for a big surgery and you lost some of your quality of life. If you want to take this a chance, so that's fine.
Excellent point, Dr. Saif. But I think now all of my colleagues on the stage, as well as the audience, they get the message that regardless if you are with the radiation or with the surgery, the point always discuss it at the tumor board. It's
Absolutely.
not one-man show. It's involving all the aspect, radiation, medical oncology, surgical oncology, pathology, as well as a radiologist. So always we have to discuss those kind of challenge cases. My next question is to Dr. Naif, one of the audience joining us and virtually. They are asking about the two-step procedure. Which kind of downsides or disadvantage of using those procedure for two-step instead of just one step, tackling the primary as well as tackling the metastatic?
First of thing, thank you, Saif. He agreed that surgery is better than radiotherapy in liver, that's very positive. For the stage procedure, if you're talking about resectable colorectal liver metastasis with primary in situ, I think most of the time we would like to do it together, like synchronous liver resection and primary resection of the colon, if the patient has good performance status. Having said that, when we do the liver resection, the colon resection, in the same time, there will be some trend toward portal hypertension. So when we do the left side of the colon, usually we do stoma for those patients because of the portal hypertension. But if the patient has poor performance status, or the patient has emergency bowel like bleeding or perforation, usually stage procedure preferred than doing synchronous resection. But like in generally, yes, I would like to do them all at the same time if the patient has good performance status.
Thank you. Thank you, Dr. Naik. So, Dr. Ahmed Zahrani, I have a question regarding the HER2. You mentioned that HER2 tests, it's preferably not to be done if the patient having KRAS mutant. Assuming you have open access, and for those small number of the patient, 3% that they are positive, although they are KRAS mutant, and as you mentioned that they have lack response to anti-HER2, you think still we need to do it for all those entity of the patient, or we can say no, this is a kind of standard of care, no need to spend the money to do HER2 tests for those patients with KRAS mutant?
So thank you for the question. I think if you are RAS mutant, I would not bother and check for HER2 new status because those kind of patients, they don't derive any benefit from anti-HER2 new. So what's the point to check on HER2 new status? So BRAF mutant patient, they don't derive, RAS or BRAF mutant, they don't derive benefit from anti-HER2.
And in the same aspect, which one of those you prefer? My Pathway, Hercules, or Montier? I mean, if you have just one option, if you are in one institution and the pharmacist, he said, I cannot bring all of those, I want to bring one, and you have to choose which one. We know that in the oncology, there is no one size fit all, but what's the best among those trials that I can use it for my patient if they...
I have to admit, the data that we have is quite limited, mainly phase 2 trials, so there is no comparative trials, but my preference would be my Pathway protocol. Trastuzumab, pertuzumab, based on the toxicity profile. They have much favorable toxicity profile. And we have learned this from breast cancer experience. So my Pathway protocol might be the best in my opinion. Trastuzumab deruxtecan is another option.
Thank you. Thank you, Dr. Ahmed. So if anyone have a question from my colleagues, the audience, I have, yes, Dr. Gibran.
Thank you so much. It's really interesting to know, to talk about the role of surgery. You know, again, talking about the evidence, if you go into the history of, for example, liver transplantation, there was no randomized trial actually behind the role of liver transplantation for HCC or liver cirrhosis, but yet still a standard of care for a limited group of patients. Definitely, the only way to know whether it is surgery or radiation is to, as you said correctly, is to run a head-to-head comparison. But again, this has been done for example, in HCC. I don't know why it's not done in the metastatic liver disease. For HCC with a limited size of less than 3 centimeters, we know that RFA is just equivalent to surgery in terms of long-term outcome. I don't know why this has not been done yet in liver metastasis. I have a question to Dr. Naif. Now, when you treat patient, again, the dilemma, if the patient has responded completely to chemotherapy and there is no residual disease on CT scan, would you prefer to go and resect the segment involved or no resection?
Thank you. This is always the debate when you have complete radiological response of colorectal liver metastasis. Some surgeons, they do liver resection for those patients. I usually don't, because it's very hard to justify doing a blind resection for non-palpable, non-visual liver metastasis. This is my number one. And patient will have like probably 40% to 50% complication rate with 2% mortality rate. We're talking about a cancer that usually it's chemo naive. So even if it's disappeared, that means they have good response to chemotherapy. So talking about the biology of the cancer is good. So I don't do blind resection of non-visual colorectal liver metastasis. Some people they do, but it's always the argument between us, to be honest.
I have a question to Dr. Mahrous. Dr. Mirbat, regarding the PRAF. Do you think in the future we'll start to use the PRAF inhibitor as a first line? Or based on what we have so far, it's a...
Well, that's a very good question. As I pointed out, that we do have now the sequence, because PRAF is it's a very difficult disease to be treated, and even with the second line, just give you 9 months regarding the combination. We are waiting for. We do have the anchor study as a phase 2, and just only the response rate was 48%, and there was no meaningful for as an upfront. But however, we are waiting for the breakwater study, which is an upfront therapy for them. But we know we got our lesson that the field is changing. So the patient with PRAF MSI, there is also study for a combination between this medication plus pembrolizumab, and also because it's a specific entity, I'm still feeling that we're still not treating PRAF in sufficient way or in satisfactory way. Maybe because MSI changing our vision regarding how we are reaching to a complete response, and the patient even has no toxicity, very good quality of life. But your point is absolutely valid, that once we have something in a second line, how about the first line? So I don't have an answer for this, but I'm just waiting for the data. In the meantime, it was it was as a post hoc analysis. They looked at the patient who received bevacizumab as an upfront. This was post hoc analysis for the Beacon study. They looked at the patient who received doublet or triplet with the bevacizumab and compare it with the look at the patient with anchor study, and they found that the sequence may increase the overall survival for the patient. But again, maybe when we are treating this patient on an upfront, there will be comparative data and we be more robust data so we can answer it. Thank you.
Absolutely. And this is what the great thing about the oncology, the evolving every once in a while. Dr. Gibran, my question is sorry, Dr. Ahmed, you want to say something? Sure. Yeah, absolutely. No, absolutely. Yes.
So my question to our surgeon and radiation oncologist. So what's your experience of combined approach, resection plus local regional therapy in order to completely eradicate liver disease, as has been done in URTC study that have compared patient with unresectable liver. They have compared, I think systemic chemo versus surgery plus local regional therapy in order to completely eradicate liver disease, which have shown really robust 10-year survival of 26%. So in the National Guard, what's your experience? Do you go aggressive with such patient combining local regional therapy plus liver resection? What's your take on this?
It depends from patient to patient. Like we discussed this patient in the MDT meeting. I just joined the National Guard Hospital, but back in Sydney, we used to do intraoperative radiofrequency ablation combination with liver resection. I think it's useful when you have a patient have unresectable bilobar liver disease. But yes, aggressive is the way to go. But in National Guard, we haven't done it yet, but definitely I will be interested to do it, inshallah. Talking about like radiofrequency ablation or cryotherapy. I have done cryotherapy because the machine was available back in Sydney in the same time doing liver resection, right loop, and cryotherapy with the left side of the liver, which have a very comparable result with the radiofrequency ablation.
Dr. Mahrous?
I do have a question to Dr. Saif, please, regarding what you're selecting criteria for the patient with SPRT versus RFA. And the second element, if you do have a patient with SPRT done for him, hepatic, and then the patient develop a side lesion, I mean, if you give them on segment 8, for example, and then the patient develop in segment 4A or beside the lesion, do you able to go for another one, or you will not do it for him? Because this is a common scenario.
Thank you. Yes, regarding those patients, we can go back and treat again, because as I showed, everything is done in retrospect. So we measure the dose before
we deliver it to the patient. So after we do a measurement to the liver dose, to all the organ at risk, if it is, okay, then we go ahead with the treatment. And we have the same measurement, like taking from the surgeon, like we need to save at least 700 cc of the liver to a specific dose to have like a good function of the liver afterward. So everything is done in retrospect before we treat the patient. And in those patients, I treat multiple of them with the recurrence after RFA and without any toxicity on the liver in the future.
We have, yes, Dr. Ali, go ahead.
Do you have a question from outside?
Yes, Dr. Al-Garni, he had one question.
I have a question actually to Dr. Ali regarding the neoadjuvant immunotherapy in patients with early colorectal cancer. So don't you think that should be the standard for patients with MSI high? Now we have a very good biomarker that we know for so many years. We know the consistent result in metastatic, and now we have some evidence in the early stage. Now we have young patients with microsatellite and stable Lynch syndrome that you can spare them from APR and lifelong stoma. So don't you think that we have evidence now that is enough to recommend MSI testing for all comers and recommend immunotherapy for those patients? Because I believe this should be the standard for those patients.
Thank you. I believe the same way. I think it should be the standard, not because we don't have more data to support this, but because actually we don't have more data, because data are already being consistent. This is MSI disease, and we know that the same argument I used. We know that why immunotherapy works very well in MSI disease, why chemotherapy does not work well in this subset group of patients. And I agree with you, it should be the standard. And you know what? I think it's coming. It's going to be the standard soon. The question is again applies to the patients that we have now currently. Are you going to start them on chemo or immunotherapy? Myself, I would really recommend starting them on immunotherapy, no doubt.
So Dr. Gibran, at the same point, for curiosity, my curiosity as well as our audience, what's happened to your patient, the second? Did you start, because you asked a question at the end of your presentation, but we don't know what's happened to the patient.
I started him on immuno.
And he's doing well, inshallah?
I'm not sure yet. We just started.
Okay.
Because I just saw him recently.
Fair enough. So your question, sorry, you want to...
This will bring us, the study, it was on dostarlimab. So are we able to use any medication, because the study it was with dostarlimab, which is not available in Saudi Arabia? Are we able to go for any immune therapy?
Of course, I did not use dostarlimab because, as I said, this is not available. I used actually Pimbro. But Pimbro is just like dostarlimab. It is anti-PD-1, not anti-PD-L1. And again, for MSI high, actually it doesn't matter. And we know, for example, for the MSI disease in the metastatic setting, whether you give Pimbro or Nivo plus EB, the outcome is still favorable compared to chemo. So I used Pimbro for this patient. Dostarlimab is not available, so we did not use it.
You want to ask something? You have
I would like to ask a technical question to Dr. Saif. You mentioned about the Fudishal that you insert in the liver, because I remember we used to have a radiation oncologist back in King Faisal a few years ago who actually used to put these clips inside the liver, but then we just learned that you don't need them anymore. So is there any improvement in the techniques, and what was the difference?
Yeah, as I mentioned, there is different machine, different techniques. So the cyber mandate, you put these clips, but then there is the MRI LINAC now, and there is also some use like the regular LINAC with image inside, like CT scan to image the patient, and those patients you don't need the clips. So actually, if you look at the data, like in the outside world, maybe 2/3 of the patient without any fiducials. and third of the patient will be treated with fiducials.
So I think we end with this session. Dr. Mahrouz, Dr. Gibran, Dr. Naif, Dr. Saif, Dr. Zahrani, thank you so much for this great informative session. I will leave the mic for Dr. Mohammed Al-Garni to end this great events, and I hope inshallah to see you next year.
Thank you very much, Dr. Fahad, Dr. Sabatin for moderating. Thank you, Dr. Mirfat, Dr. Ali, Dr. Naif, Dr. Saif, and Dr. Ahmed for this excellent session after lunch. We have come to the end of our conference. Thank you all for being with us. Thank you for our IT team. Thank you for physical attendance. Thank you for also our virtual attendees. And thank you for the sponsors, and looking to see you soon in another meeting, inshallah. Assalamu alaikum.